A very precious morning to one and all present here. Myself, Dr. Priyanka,
I, Dr. Raksha Jaiswal.
take this honor to welcome each one of you who have gathered here for the CDE program, CBCT, a versatile diagnostic tool.
We welcome all the dignitaries, respected Dean of Swargiya Dadasaheb Kalmik Smriti Dental College and Hospital, Dr. Deepak Nagpal sir, respected guest speaker, Dr. Prashant Jaju sir, respected head of department Oral Medicine and Radiology, Dr. Ashish Lanjekar sir, respected UG director, Dr. Jaikumar Gade sir.
On behalf of Swargiya Dadasaheb Karmik, Smriti Dental College and Hospital, we are extremely pleased to welcome our esteemed guests and all who have gathered here for the CDE program.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. It is our culture to remember the Almighty before everything we do or start. So let us start this program with the blessings of Almighty. I would like to invite our respected dignitaries for the traditional lamp lighting.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्तामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा नानाधर्मनिगूढतत्त्वनिशिता यत्संस्कृतिराजते सेयं भारतभूर्नितान्तरुचिरा मातैव न सर्वदा तस्या उन्नतिहेतवे हि भवता ज्ञानं तथा मे बलं सम्पन्ना बलशालिनी विजयतां मे मातृभू सर्वदा मे मातृभू सर्वदा मे मातृभू सर्वदा.
Thank you. I would like to call upon Lakshmi Kalmik to welcome our respected guest speaker, Dr. Prashant Jaju sir.
I would like to call upon Bhakti Randive to welcome respected Dean Dr. Deepak Nagpal sir.
I would like to call upon Dr. Komal Deotale to welcome our respected head of department, Dr. Ashish Lanjekar sir.
I would like to call upon Bhakti Randive to welcome respected UG Director Dr. Jaikumar Gade sir. Now, I would like to call upon the dais our respected head of department Oral Medicine and Radiology Dr. Ashish Lanjekar sir for welcome address.
A very good morning to all of you and all the dignitaries present on the dais and off the dais. I, Dr. Ashish Lanjekar, Professor and Head Department of Oral Medicine and Radiology, Swargiya Dadasaheb Karmik Smriti Dental College, welcomes Dean Sir, Dr. Deepak Nagpal Sir, UG Director, Dr. Jaikumar Gade Sir, and Dr. Ramhari Sir, and today's guest of honor and guest speaker, Dr. Jaju Sir, and all the alumni, all our other faculty members, my seniors, my colleagues, and the people who have joined online for this particular CD program. Today, along with our CDE program details, I would like to share with you some of the highlight of my department. The department was established in 2008 and the first batch passed out in 2010. Our first postgraduate batch passed out in 2015. This has been a long journey and we have delivered 100% results for our PGs as well as for UGs, and many students, they have secured gold medal in our branch also. Plus, I am extremely delighted to share with you all about additional things which we have imbibed during our journey. Our department has also started fellowship program like last year, and we are running our PhD program also. I'm also delighted to inform you that our college is in the process of patenting MTA, indigenously produced MTA, and the patent will be granted soon. For that same patent filing and for the same project, we got PM Fellowship also, prestigious PM Fellowship award, which is very rare to be granted to a dental college. Okay, today we'll be focusing on more or less on the basics of the CBCT plus imaging details and how to how to go about from the basics of like orthogonal planes and all that. So that will be very helpful for UG as well as postgraduate student. So on this with this short introduction, I am extremely thankful to the Sirona also for their constant support throughout the entire planning and execution of the entire CD program. I am also thankful to Sharad sir, our Honorable President, Hemant sir, our Secretary sir, and Dean sir for his constant support, and my faculty members and my PGs for their constant support. Thank you. Thanks a lot.
Thank you, sir. Now we begin with the main section of today's program, for which we all are here. We request all the dignitaries to take their seats off the dais. Thank you.
Cone beam computed tomography is a conventional tomography's improvement developed especially for the assessment of maxillofacial region. Within the dental areas, the one that most used CBCT was implant dentistry. However, with the evolution of technology and its benefits, it has been increasingly requested by different areas as it allows the dentist to verify the bone's morphology in addition to various diseases, dental and bone trauma, maxillofacial injuries, endodontics, impacted teeth, TMJ changes. Dentists must be aware of the technological advances that occur in the field of dental imaging in order to manage diagnosis and treatments more efficiently, thus avoiding possible errors. So, to enlighten us about CBCT more briefly, I would like to hand over my mic to Dr. Priyanka to speak few words about our guest speaker.
Thanks, Raksha. I'm excited to introduce our respected guest speaker, Dr. Prashant Jaju, from Pune, Tithe Kai Une, a land which is also known as Shikshanacha Maherghar. Dr. Prashant sir, who is an officer on special duty, professor, guide, and head of Department of Oral Medicine and Radiology of Rishiraj College of Dental Sciences and Research Center, Bhopal. Director of 4 CBCT centers in Bhopal and Pune. Dia Dental Imaging, Centers Global CBCT in Kharadi, Pune, in 3D Edge CBCT in Swargate, Pune. He is an editor in chief of CBCT magazine and oral radiology section, key opinion leader in Dentsply and Sirona Imaging India. He is a certified CBCT trainer and expert in digital dentistry, a gold medalist from the Pune University. He has trained oral maxillofacial radiologists and dentists for the CBCT in India, Nepal, South Africa, Dubai, Iran, and Turkey. Now, I would like to request Dr. Prashant Jaju sir to come forward and enlighten us with your vast knowledge and such a great experience.
थोड़ा नहीं तो खाली थोड़ा खाली है लाइट्स बंद करूँ क्या am I audible yeah, okay. Good morning everyone at the outset I'd really like to thank Kalmegi Dental College for giving me this opportunity to present my work on CBCT. My teacher, my senior is sitting in front of me, Sathavane sir. So when in my UG days, in fact, he had visited our college in Nasik. I am basically from Nasik. So that time sir had visited and we had a wonderful interaction that during our UG, I think, convention, if I remember, way back in 2000, early 2000. Sound nice. Okay, I believe yesterday you had a fruitful interaction with Dr. Burak on integrated implantology. Ideally, it would have been a perfect scenario if we had begun with CBCT and then entered into the integrated implantology world, but because of the clash of the dates, we had to prepone that event. So my topic in today's would be on CBCT, where we would be starting with what is basics of CBCT, why you need CBCT, and then we move forward to applications. And I think there's a special request for integration with CAD-CAM with CBCT, which I'll be showcasing also a couple of cases of how to do CBCT CAD-CAM interaction. Slides. Switch off करा ना light. Images clear दिसणार नाही. ती main त्याचे पूर्ण light त्याच्यावर project करतो. I always begin my presentation thanking to most important people in my life. My better half, Dr. Sushma, she's an endodontist. I travel a lot, so she takes a part of my care of my family as well as my center. And my guide, Dr. Prashant Suvarna. I am his first student, and whatever I am is because of my guide. There's a very interesting story how I entered into CT or CBCT, you can say. I'm a Diva Patil Pune's first batch student in PG. So my thesis topic earlier was a determination of serum ferritin level in aptus patient. So within 1 month, my guide got changed and Dr. Suvarna entered into the scenario. And he just one day called me up and he said, pre-evaluation of implant sites by DentaScan. This is your thesis topic. And believe me, when I'm in first year, pre-evaluation hota kya hai, implant hota kya hai, DentaScan hota kya hai, pata nahi hai. He gave me an address in Bombay. He said, this is a diagnostic center. It's a medical radiologist. Go there, meet them, and just see how it can be worked upon. So that's how my journey began with CT, with CBCT in integrated implantology way back in 2005. So he is my biggest strength, my biggest supporter, as well as my biggest critic. So whatever I am, I always thank my guide, and I always tell my students, or wherever I present, you should always respect your teachers. They are the person or guides, especially the PG students. They are the people who will be giving you the right advice at the right time. I began my CBCT career in 2009, in fact. One of the earliest, or you can say few maxillofacial medicine people or OMR people, how we call it, who are doing exclusive radiology practice. I do exclusive radiology practice since last 15 years. I don't have any clinic. It is just purely radiology attached to 15 centers pan India, and we have our almost five in fact. In Pune, we have in fact 3 diagnostic centers and 2 in Bhopal. So these all places, repeat Pune, Raipur, Nagpur, in fact, associated with Nagpur Center since 2011. It's a long tradition of joy with Genesis in Nagpur, in fact. With Sirona again, it's a long journey since 2011. First machine, Orthofos, was installed at my center in 2011. Then the next machine I think which you have is Orthofos SL3D. So that first machine was installed in Bhopal at my center in 2015. Then we had Orthofos S, again their first machine, which was again installed in my center in Pune. The only machine which is missing from my, you can say, domain is their latest machine, that is Axios, but that's installed somewhere else. It's a bit expensive machine and I cannot afford it. This. So there is a danger when we are bound by 2D concepts in a 3D world. In today's time, you go to any theater also, there is every movie which is showing in 2D and 3D, right? In fact, in medical radiology, we are entering the world of 4D also. So if you are having options of 3D, why would you look at 2D? So sometimes there are things which you cannot completely rely on 2D. You have to move on to 3D. And this line is given by one of the famous gentlemen, and he's a famous implantologist, Professor Scott Gans. He, if I don't know, he's from US. He does a lot of work in integrated implantology. I was fortunate enough to meet him at Florence, and he is one of my colleagues, you can say, in our computer-aided implantology academy. So he's one of the founding members, and that's where he presented this word where he said that we are always bound by danger when we are just relying on 2D imaging rather than 3D imaging. Just a brief overview of how the maxillofacial radiology has evolved. On 8th of November last week, we celebrated the International Radiology Day. That's where we began our journey in you can say radiology. In dental field, we started with our periapicals. Then in 1970s, we moved on to the panoramic radiograph. Then we had the various introduction in 3D, like during my PG time, which was more concentrated on CT, MRI, ultrasound. In early 2000, CBCT was introduced to the world, and by 2006-7, it was introduced to India. Now we have almost, we can say, 500 to 1,000 centers across the countries, and various, whether it's diagnostic centers or private practitioners who are using CBCT. In couple of years' time, trust me, you're also going to get a dental MRI. But the usage of dental MRI would be more restricted to your TMJs and non-odontogenic infections rather than to implantology. But that's one option which is quite wide open. So that's how your imaging has evolved. Now there are times when you are doing some treatment like a simple restoration, a simple root canal. But when you are completing a suppose a central incisor root canal, complete कर लिया, patient 2 दिन में आता है फिर बोलता है मुझे दर्द हो रहा है. You feel everything is fine. Same thing with an implant. A simple case, you have done an implant, patient within 2 days complains to you there is a burning sensation, there is a paresthesia or something like that. So there are times when you have unsolved cases, and these are the times where you are completely perplexed. What is happening? I followed every protocol, I have done everything right. Why still the patient is in pain? And that is the time when sometimes your 3D imaging tool like CBCT can come to your rescue. I'm sorry, I'll just skip back first. Yeah, we very well know what is the structure is, right? This is a Taj Mahal, right? This is also a Taj Mahal. What is the difference? It's an unobstructed view. You can see every aspect of Taj Mahal from this picture. But the earlier picture was a two-dimensional picture where you were not able to see the other dimensions, right? So that's how is the difference between your 2D imaging and a 3D imaging like CT, MRI, or a CBCT. They are going to give you an unobstructed view without any superimposition, without any magnification, where you can easily find out any pathology if it's there. So what are the limitation of conventional radiograph? I am a maxillofacial radiologist teacher. I would not recommend that आप हर patient के लिए CBCT करो. No. But there are indications where you have to do a three-dimensional imaging. What are the limitations of your conventional imaging? You must have learned during your third year, final years, or during your PG time. I'm just revising it. 30% of bone loss is required before it can be seen on a radiograph. You very well know it, right? I believe there are final years and intern students here. You know this line, 30% of bone loss. So whatever you see on your periapical radiograph, the 30% more destruction has actually happened already in the oral cavity. Okay, but you require the initial 30% to be seen on a radiograph. That's the first limitation. Second limitation, third dimension. If this is the pointer or something like that, in a periapical radiograph, you cannot differentiate whether it's a front side or a back side. Okay, so the third dimension, this dimension is missing. So that's not there. In a panoramic radiograph, your palatal and lingual structures are always superiorly placed. Now, why this is? In a panoramic radiograph, the X-ray beams goes like this towards the cranium. So your lingual and the palatal structures are always superiorly placed. So in the oral cavity, it is not like that, right? In the oral cavity, they are equally placed. But in your panoramic radiographs, they are always superiorly placed. So it's a misrepresentation of the structures. And lastly, life-size images are difficult to achieve. Please understand, be it your panoramic radiograph, be it yourself, there is always a magnification. No company in the world can claim that they are giving life-size images. No. There is always a magnification with it. Like in your orthophos SL, there is 1:1 point, I think 1:10 is the magnification factor. And with CEF, it is 1:1.25 something, it is the magnification factor. So there is always a magnification factor which is associated. Life-size images, you don't get it. It is only in CT, MRI, and CBCT or three-dimensional imaging, you get life-size images. So these are your limitations of your conventional radiographs. Can anyone tell me what is the historical importance of this radiograph? It's the first human radiograph, you can say. Do you know how much was the exposure time? It may be in minutes. I believe it's something like 10 to 15 minutes. Now just imagine Bertha Ronjan had to stand like this for 15 minutes just to get this thing radiograph. If I tell my wife to stand like this for 15 minutes, just imagine. So this is your CBCT machine. You all have seen the CBCT machine in your department. Within 14 seconds, you can scan your entire maxillofacial region. So that's the advancement that maxillofacial technology has achieved. From minutes, we have entered into seconds. Okay. So welcome to the world of cone beam computed tomography, and the abbreviation stands for CBCT. Why? Because the beam which is coming out from the machine is cone shape. Okay. So when you compare this with a CT scan, in a CT scan we are having something called as fan shape beam. Okay. So this is your CBCT where you are having a cone shape beam. This is a CT scan machine where you are having a fan shape beam. So that's the basic difference between the technologies. Now, people will ask me, sir, why are you preferring CBCT over CT and in your dental environment? Well, I have my reasons and I have listed them. My first reason is a shorter examination time. As I already have discussed, within 14 seconds, I can scan my entire maxillofacial region. Now, you all have taken a periapical radiograph, right? I believe everyone has taken. Now, just imagine, agar exposure time ज़्यादा रहा तो patient हिल जाता है. What you have to do, you have to just have to repeat the radiograph. Similarly, with CBCT, I have to make my patient stand. If I tell him to just stand for 1 minute, there are chances that there would be always a movement. So then I have to again repeat it. So that is eliminated because of the shorter examination time. Within 14 seconds, I can just quickly scan the area and without any minimum distortion or minimum movements. Then the other advantage, which is very useful for patient as well as us, is that we can limit the beam. That means if I just want to scan this region, I can select an option in the machine where I can just select and scan this region. I don't have to expose my other region, area of the regions. Okay, that's a big advantage over CT scan, and that is called, the concept is field of view. Okay, so in field of view, it means हमको कितना area expose करना है और उसमें कितना radiation exposure होता है. So if I select a normal small area, obviously the radiation exposure would be less. But if I select a larger area, the radiation exposure to the patient would be more. So that's an advantage which we don't get in the CT scan machines. Subsequently, you have a patient dose reduction. And the last, and for me, I think the most important point is something called as isometric voxel. Okay, any PGs, oral medicine PGs sitting here? We have PGs here? Yeah. So you know what is something called as pixel and voxel? What is pixel? Picture element. Okay. आपने RVG लिया हुआ है. RVG में something, there's a terminology called as pixel. It's in two-dimensional picture. It's called the picture element. Voxel is a three-dimensional cube. So एक cube के अंदर pixels रहते हैं. So a voxel or cube will have three axes. It will have an x-axis, a y-axis, and there is a z-axis. Okay. Now understand, in your CT scan machine, when exposure happens and the machines are the images are getting reformatted, your x is equal to y, but it is unequal to z. It is an anisotropic voxel in your CT scan machine. But in CBCT, x is equal to y equal to z, and that is called as an isometric voxel. आप बोलोगे सर इतना क्यों पढ़ा रहे हो, उसमें हमें क्या इंपॉर्टेंस है? Well, it is very much important to you because we are dealing with finer structures. We are dealing with the pedal space, we are dealing with the pulp chambers, we are dealing with the lamina dura. So these finer structures can only be observed because of the isometric voxels. You can observe in CT scan, but CT scan की clarity और इसकी clarity में differentiate देख रहा हूँ. CT scan में जो pulp chamber दिखेगा, जो pedal space दिखेगा, जो lamina dura आपको दिखेगा, that would not having that clarity what a CT scan CBCT has. And what is the reason? The reason is because of your isometric voxel. So that's the biggest advantage as far as I feel is why CBCT has to be preferred in dental applications over a CT scan. Is it clear? I'm seeing some people are just dozing off. I'm going to ask questions in middle, okay? So let's come to a very interesting point, and that is called as field of view. Now, why field of view? Because मेरे जो oral medicine वाले PGs है, उनको आप दूसरे डिपार्टमेंट की PGs बोलते हो कि चलो ये CBCT स्कैन करो. अभी वो पूछते भैया CBCT स्कैन करना है, बट कौन सा करना है? बोले 6 का कर दो. चलो 6 का कर दिया, बट पर्पस तो बता दो कि स्कैन किसके लिए चाहिए. Whether you want it for an endodontic purpose, you want it to assess for a pathology, you want to assess for an implant purpose, and that's where your field of view concept comes in. Now, can anyone from behind tell me which radiograph will have a better resolution, a periapical or a panoramic radiograph? Periapical. Yeah, you're absolutely right. So this is how your concept of field of view is this. अगर आपका field of view narrow रहेगा, your resolution would be better. If your field of view is broader, the resolution would be poorer. So whenever you have an endodontic purpose, you want to detect a periapical pathology, you want to detect an fracture, your field of view should be smaller. So my oral medicine PG would then select a smaller field of view of 5 by 5 to scan only that limited area so that she get a better resolution and she can give you the diagnosis for which you have done the scan. Understood? Then we have another slightly larger field of view, and that's 8 by 8, which you have. Now this field of view is more important for your implants, for your pathologies, for your periodontal problems. Why? Because there we don't have to deal much with the finer structures. हमें सिर्फ थोड़ा broader structure दिख जाता है, चल जाता है. Okay? So in your 5 by 5, you are getting a resolution of 79 microns. That's one of the lowest. In your 8 by 8, you get a resolution of 150 microns. तो अब difference देखो कितना आ रहा है. एक में 79 का आ रहा है, दूसरे में 80 microns का आ रहा है. Then you have a larger FOV, more than that, and that is 11 by 10 FOV, जो आपके machine में है. Now that we basically use for either for any maxillofacial pathology or a trauma patient, or we generally do use it for airway analysis, because I wanted to see the posterior part of the spine as well as the airspace. So I generally prefer doing it in 11 by 10. Or sometimes I use it for my maxillary canine impaction, because maxillary canine generally are placed mesiodistal like this, and it's touching almost to the anterior wall or the buccal wall of your sinus. So मुझे coverage ज़्यादा चाहिए रहता है. So then I can select 11 by 10. So depending upon the indications, the PGs in the oral medicine or the staff in the oral medicine have to select the field of view. Similarly, if you're doing in your private practice, आप जब लिखते हो CBCT center पे, please try to mention the purpose of the scan. It becomes very easy for us. अदरवाइज आपने फ्रैक्चर के लिए लिखा और मेरे को तो क्या, मेरे को 5,000 रुपये कमाने हैं, मैंने फुल CBCT कर लिया, बट देन योर डायग्नोस्टिक वैल्यू इज नॉट देयर. ओके, द पर्पस ऑफ द स्कैन इज नॉट सॉल्व. सो मेंशन योर, कोई पीस ऑफ पेपर जो रहता है थोड़ा लंबा रहता है, बट उसमें अगर आप 5 मिनट लिख के दे दोगे वो आपके फायदे के लिए रहता है. So that's why, because we can select the field of view. In the Neo machine which or Sirona has, that's called the Axios, they have increased the field of view, and that is 720 by 13. So I can cover my entire region in the scan. Again, this is for more of maxillofacial trauma purposes, orthodontic surgery purposes. Okay, so this is the concept of field of view. Now coming to just related with field of view is the resolution, which I have already discussed with you. In your machine, you are having 3 doses: a low dose, a standard dose, and a HD dose or a high definition dose. It is inversely proportional. जितना आपका resolution poor रहेगा, radiation dose कम रहेगा. ठीक है, जिस दिन मैंने high definition images ले लिए, वो radiation dose जो patient को delivered होगा, that would be higher. Okay, so you have to understand that thing. If you are taking a low dose, the resolution of the scan would be poorer. Like, I don't know whether you can see it because of the slides, but there are too much of grainy images here. But when you see an HD image, it is very smooth. Why? Because the resolution of this image is better than this. But the radiation dose given in the delivered to this patient is low in this case, it is high in this case. Okay, so depending upon the indication, you can select that parameter in your machine. Like an example, post implant CBCT scan, you just have to verify whether your implant has been placed properly or not. And if someone wants to do the evaluation on CBCT, she can or he can do it with your low dose, because उसमें मुझे resolution से लेना देना नहीं, I just want to see the implant, and at a very less excuse me, radiation dose. One more thing, if you go to the oral medicine department, after every exposure, there's a radiation dose which is mentioned there, right? If you take a low dose scan and see the reading, it is actually lower than a panoramic radiograph. So that's an advantage, where you can get a 3D image also, and you deliver a less radiation dose also to the patient. So that's the advantage of your low dose. But wherever required, you can use a standard dose or a high dose. Same images, I'm just showing. During my PG time, we were dealing with a concept called as ALARA, as low as reasonably achievable. But in today's time, we are following concept as ALADA, as low as diagnostically acceptable. So depending upon what type of indication you are using, you can use this principle of ALARA to ALADA. That's one of my article which I had published, where depending upon, suppose I want to post implant, I use a low dose. I want to do a pre-evaluation implant sites, I would do it in a standard dose or a high dose, as long as it is giving me a diagnostic information. So that's how we follow the concept of ALADA. We are no longer following the concept of ALARA. I'll just skip this. Okay, so this was basically an introduction to the CBCT and basics of CBCT. Is it clear for you all? Okay. Now coming to the interesting part, which for you all, everyone is there, and that's the applications of CBCT. we'll begin with the first part, and that is implantology. See, when I was doing my thesis on DentaScan, in DentaScan it is nothing but a software and CT scan machine, but हमें सिर्फ measurements करने आता था. We were just able to do the measurements, and we used to give it to the implantologist, and then he used to place the implant whatever he wished to place. In current time with CBCT, I can do everything on the CBCT software. I can do the measurements, I can do the nerve marking, I can select the area where I want to place an implant, I can actually place the implant on the computer screen itself and select my final dimension. And in 2 days time with integrated implantology, we can also do the design, the surgical guides. So that's the advancement we have in dental implantology with on CBCT. In the earlier 2000 when CBCT was introduced, it was basically the indication was implants. In 2022, we are at the end of 22, trust me, the indication of implant is just on the second number. The first number is in endodontics. Almost every company machines is having an hybrid component which is giving you a smaller FOV just for your endo purpose. In my center, daily I can, trust me, 5 to 7 cases are just for RCT. Because in today's time, dentists just want to know whether I should jump into and do a RCT or straight away do implants. So the indication is more. So my first indication today's time is dental endodontics, then in coming to implantology and then to other indications. The next and the fastest growing branch which is happening is sleep apnea. Again, because of CBCT, orthodontists are jumping into this sleep apnea field, be it orthodontist or prosthodontist, just to assess the airway, and we are almost 60% of our population is suffering from snoring. Okay, so for that initial evaluation, CBCTs are getting used just to evaluate the airspace in this. So that's one of the interesting branch which is again growing. So we will be seeing all those applications, but we'll begin with the most important branch, and that is implantology. 90% of failures occur during treatment plan, and failing to plan is planning to fail. And I believe this concept is there in every aspect of our treatment, just not implantology. If you have a particular case, you do a proper diagnosis, then you have to do a proper treatment plan before you actually venture out and do the treatment. So that's where, otherwise, because if you fail into this, you will be failing big time. Now this is 2022's current implant team, where you have an implantologist, you might be having an oral surgeon, you might be having a prosthodontist, a periodontist, but you have to have an oral medicine guy because he is going to be your third eye in your entire implant scenario. Okay, so without him, today's time it is difficult to proceed with the implant practice. Why? Because sometimes 2D imaging gives you a blind picture, and over relying on 2D imaging sometimes can land you in big trouble. Has anyone seen a picture like this? कभी देखा है ऐसा picture, panoramic radiograph? Anyone? I think the senior faculty must have seen such picture. This was a panoramic radiograph for an implant purpose. So what we used to do, and this is my PG time also, that there has to be a night guard sort of thing, and उसमें metal ball bearings, जो bicycles में ball bearings मिलते हैं ना, वो metal ball bearings उसमें embed करके हम लोग OPG scan लेते थे. Why? Just to calculate the magnification factor. Okay, because हमें dimensions पता है उसके, OPG पे कितना dimension हम उसको calculate करते थे. Then based upon the magnification factor, we used to measure the length. Suppose I want to place an implant here, हम उसका length का measurement करते थे. Why? Because I already told you in the beginning, OPG machines or OPG scans always have a magnification factor. So to calculate that magnification factor and get an accurate measurement, we used to follow this system. But this used to give just the length. Width was not possible on your OPG machines. Either you have to do on the clinical examination आपको करना पड़ता था, या bone mapping used to be done just to determine the width. So, but this was very unreliable method of getting a proper accurate measurements. So what used to happen? Well, the problem used to be there could be a complete misdiagnosis of bone volume. आपको OPG में लग रहा है 10 mm का width length है, and when you open up the site, it is hardly 8 mm. So it was total misdiagnosis. So if to avoid misdiagnosis, the implantologist used to क्या करते थे, अगर 10 mm का है, चलो मैं 8 mm का भी implant रख लेता हूँ, मैं 12 mm का भी रख लेता हूँ, मैं 9 mm का भी लगता हूँ. तो जो dimension available रहेगा, मैं वो implant select करके place कर देता. So what used to happen, you has to keep a large inventories in his clinic. एक दिन implant जब surgery रहती थी, पूरे dimensions के implants रखने पड़ते थे. So that used to be a complete misdiagnosis of the cases. You could also sometimes open up the site and then realize, oh, there is no bone, I need to do an indirect sinus lift or a direct sinus lift. So again, you have to inform the patient. Or sometimes you have to abort the surgery. So again, this trouble used to be there. And why this? Because there was overzealous dependence on your two-dimensional imaging. So that has to be avoided in today's time, because every patient Google बाबा से पढ़ के आता है. वो तुम्हें थोड़ा एक्स्ट्रा ज्ञान दे के जाएगा कि बाबा ये क्यों नहीं कर रहे हो, अब ये क्यों नहीं कर रहे हो. Why? Because the data is available to him very easily online. So we have to be very careful and very sure what type of treatment we are going to deliver to the patient. This is one case. Now this is a reconstructed pan. Is this implant fine for you? अच्छा लग रहा है ना? Perfect implant है, कोई दिक्कत नहीं. Sagittal image में भी लग रहा है. Good. But now see this. Is this implant fine? No. It's gone off. It's gone beyond the cortical plates. See the axial images now. ये दिख रहा है implant? ये bone से बाहर आ गया है. Why? Because the implantologist completely missed the concavity which was there on the buccolabial side in his clinical examination, in his two-dimensional imaging. And after the placement of implant, when a CBCT scan was done, then he realized that there was a concavity. So these are the blunders which can happen, which we cannot give it in today's time to the patient, otherwise he'll sue you. So your treatment planning, your diagnosis has to be perfect. And again, I'm telling the same thing. Wherever you require, do a three-dimensional imaging. Wherever you require. I'm not telling you just throw out two-dimensional imaging. No, they have their role. But wherever required, you have to use your three-dimensional imaging. So what will happen if X doctor sends a scan or a patient for implant purpose to the oral medicine department? What is the job of oral medicine people? Well, for implants, they'll tell you how much is the bone density. Oh, sorry, bone quantity means height kitni hai or width kitni hai, ek particular site ke upar. The second information the dentist or the radiologist is going to give you, what is the quality of the bone. This is a controversial topic which I'll discuss in few later slides, whether CBCT can give you HU values or not. The CBCT will tell you, or the radiologist will tell you, what are the landmarks you are going to see at that particular implant site, which you should know as an implantologist. Is there any variation in the ridge type or a variation in the shape of the ridges? That also the implantologist will be knowing. And is there any concavities which he sometimes get missed? So all these findings is the job of the oral medicine people to give in the report to the implantologist. So how do you measure the available bone? First criteria. So we measure the bone in two criteria. One is the height and the second is the width. So height, we measure it from the crest of the ridge to the nearest anatomical structure. So if it is in the anterior region, it is the incisive fossa or the nasal cavity, which in the posterior region, it's the floor of the nasal cavity, maxillary sinus. In the mandibular anterior region, generally it's the lingual vascular canal or the inferior border of the mandible. Then in the premolars, we have the mantle foramina, and in the posterior region, we have the mandibular canal. So whichever structure is nearest, my height will, or measurement of the height will stop short of it. And width measurement, we generally do at the crest of the ridge. Now, different implantologists have different school of thoughts. Some implantologists prefer the measurement of the width at the crest, whether there is bone available or not. Of one side, they just want the measurement from the crest. Some implantologists say that हमें measurement दो आप crest के ऊपर 2 mm नीचे दो और 2 mm नीचे दो 2 mm के हिसाब से दो. So that's the other class. Then third, people say that you give us the measurement wherever there's an intact cortical plate. So just imagine आपके extraction कर लिया, कभी-कभी cortical plate extraction के साथ निकल जाता है, तो इस तरह का scenario रहता है. कभी-कभी ऐसे रहता है, कभी-कभी ऊपर infection रहता है. So depending upon the indication or depending upon what school of thought that implantologist is, we have to give the measurements of the width. But generally, what I follow, I generally give at the width measurement wherever there are two cortical intact plates are there. From there, we do the measurements, wherever, whether it's at the crest or at the middle level, whatever it is. And the height, we measure it from the crest of the ridge to the nearest anatomical structure. Like this. Suppose this is incisive, your anterior maxilla. We measure the width from outer cortex to outer cortex to the nearest anatomical structure. Like in this case, it's the nasal floor or the hard palate. Now, how much is the length? 14.5. Now 14.5 का मैं implantologist को नहीं बोलूँगा कि आप 14.5 का implant डालो. No, I will reduce 2 mm from it. Why? Just for my safety sake and for my implantologist safety sake, that even if he goes 1 mm extra, he would be safe. Otherwise मैंने 14.5 का बोला और उसने 14.5 तक डाला, and then he would just 0.1 mm भी extra गया, तो he would perforating the anatomical structure, which we don't want. So we will recommend him to place an implant of 12 mm, so that even if he's go 1 mm extra, he would be safe. Are you getting it? Okay. And for the width, suppose the width is how much? 7.7. In an ideal scenario, whenever you're placing an implant, at least 1 mm of bone should be from the either side. So आपका implant properly osseointegrate होता है. So if it's 7.7, I generally give a maximum of 5 mm width implant. Okay. So this is how you're going to select the height and width. Is it clear? Okay. Now just one question from the PGs, in fact. According to you, what is an important criteria? The height or the width? How many PGs are there? You can just raise your hand. Anyone has done implants? Or anyone placed implants? No one? No one is placed? You're placed. So according to you, what is an important criteria? The height of the implant or the width of the implant? Width or height? Width, right. Why? No, that's not. Ideally, it should be the width of the implant, because the surface area increases. If the surface area increases, your distribution of the force becomes easier. That's the scenario. So whenever you have a choice, it's always better to go for a broader implant rather than a longer implant. Okay? And why this is for my oral medicine people? Because we are not used to doing implant planning. हमें सिखाया नहीं जाता है, तो हमें लगता है जो लंबा implant है वो सबसे अच्छा रहता है. You have to think in the direction of what the implantologist want, what the clinician want. That should be right thinking, because at the end of it they're gonna call you and they're gonna ask you, भाई तुमने 15 mm का implant डाला क्यों है और 3 mm का width डाला हुआ है. अभी my posterior maxilla में 3 mm का implant और 15 mm के higher अगर मैंने implant दिया, it is not going to work because the masticatory load is not going to take that. The implant is going to fracture. So you have to, this is for the oral medicine people. So this is for the posterior maxilla, again same, from the crest to the nearest anatomical structure. For the anterior mandible and for the posterior mandible. Okay. So this is how you measure the height and width of the implant. Now, you are having, I think, CBCT for almost 3 years now. 3 years is zyada ho gaya. After today's lecture, go back to your oral medicine department and see all the scans. And I would request you to see the region between premolar to premolar and check out the variation in the anatomy. There is a tremendous variation in every human jaw. And this was considered by the implantologist as the safest zone to place an implant. It's a myth. There is a maximum variation happening in this region and maximum complication happen in this region. So you have to see the CBCT scans when you're doing the implant planning. Just don't rely on my report or any oral medicine person report. आप खुद देखो scans. उसमें खुद variations देखो. Then you will understand that the human jaw anatomy is having so much variation. And one of the variations, or I will not say a variation, but a critical structure which is there between 3.1 and 4.1 region is something called as the lingual vascular canal. So you have the sublingual artery coming in from the lingual side and entering into the cancellous bone. So whenever you're doing an implant planning, your measurement should be from the crest of the ridge till here. It is, I am not going to go to the inferior border of the mandible, because if I go to the inferior border of the mandible, I may just perforate the lingual vascular artery. And the literature suggests that there could be serious complication for it. Yes, but if the implantologist is confident enough to manage that artery or the bleeding, he can very well go beyond the dimensions of the lingual vascular artery. But for as a radiologist, when I'm writing on my paper, I'm supposed to give this variation of the anatomy or this anatomical structure in my report. It's then the implantologist call whether he wants to respect that thing or even he wants to go beyond that thing. Okay. So this is how your lingual vascular artery appears. This is a double lingual vascular artery again. You can very nicely see this is the buccal side or the labial side. This is your lingual side, and you can see two channels here. So this is your lingual vascular artery. It's not a fracture. Okay. So 3.1 or 4.1 के बीच में दिखता है. The second variation, and that is called as the accessory mental foramina, and this is one of the most commonest thing. And I have n number of implantologists telling me we have placed an implant here और जिस दिन इम्प्लांट डाला उसके दूसरे दिन से बर्निंग सेंसेशन चालू हो गया या पैरास्थेशिया हो गया. Why? Because they were not able to identify the accessory mental foramina which is there. So what you're seeing is here is your main mental foramina, but उसके ऊपर एक छोटा सा round structure है, that is actually an accessory mental foramina. And not necessary it is going to be always superior. It could be inferior, it could be anterior, it could be posterior. The simplest thing is जब भी CBCT स्कैन ओपन करते हो ये 3D पिक्चर ओपन करो और बस एक बार रोटेट कर लो, उसमें आपको तुरंत समझ में आ जाएगा उसमें वेरिएशन है या नहीं है. So this is very important for your planning in the mental foramina region. Okay, so accessory mental foramina is one of the commonest finding we get into the human jaws. At least in Indian jaws you can very well see it on a regular basis. Is it clear? Is it interesting? Good. Now coming to the most controversial topic, and that is quality of bone. When I was doing my thesis on pre-evaluation implant size, we were doing on the CT scan machine on Denta scans. So we used to follow Kalmish classification of D1, D2, D3, D4, D5 bone. Okay. In today's time with CBCT, please hear it out clearly. We cannot follow HU values on CBCT. The technology of CBCT and CT scan is totally different. So the HU values which are applicable on CT scan machines cannot be applied on the CBCT machine. And for that, I would recommend my oral medicine PGs to read, and even fact the PGs of other department, to read an article from Triple O by Dr. Robert Molteni in 2016, which was where he described why Hounsfield units cannot be used on the CBCT. It was awarded the best paper for that year, and it is a very interesting paper where he says that if this structure's density I know, suppose there is a particular value to this density, I know it, and when I do a CBCT scan in 4 different quadrants, applying 4 different parameters, same structure का density different आएगा, same structure, ठीक है? So it is a multifactorial. CBCT में मैं कितना KV अप्लाई करता हूँ, कितना MA अप्लाई करता हूँ, उसमें बहुत सी scattered radiation कितना है, क्या artifacts है, इससे influence होता है मेरा HU values जो इस पे आता है, जो softwares देते हैं. In fact, CBCT gives you something called as gray values. आपको क्लिक करो ऑप्शन और वहाँ घुमाओ तो वो एयर में भी -100 दिखाएगा, इनामल में 3000 दिखाएगा, बट उसी का पेशेंट का आप अलग स्कैन लो थोड़ा डिफरेंट पैरामीटर्स में तो वैल्यूज चेंज हो जाएंगे. सो पर से CBCT gives you an subjective assessment of bone quality. It does not give you an objective assessment. 70% whatever values you can see on CBCT would be accurate. 30% it could be plus minus. ज़्यादा भी हो सकता है, कम भी हो सकता है. So you will ask me what is the best method? The best method, if you want an objective assessment of any bone density of particular region, DEXA scans are the only method available. You do a DEXA scan, you get a proper value of that region in an objectively method. Or the second method is your first drill which goes into the bone. That is going to tell you what type of bone you are dealing with. So CBCT per se gives you accurate 70%, 30% it's just plus minus. So it's basically a subjective assessment what it gives. Is it clear? Second thing is the terminologies bone density and bone quality equal. During our times, you used to follow bone density हम बोलते जाते थे. In today's time, the terminology is different and it is called as bone quality. What is bone quality? It is bone density plus 3-dimensional orientation of your trabecular pattern. Again, a question to the PGs: which bone is important for osseointegration? A cancellous bone or a cortical bone? Why? Why? Your answer is right, but I need the reason. Yeah, because cortical bone is basically a dead bone. Your vascularity is going to come from your cancellous bone. So your cancellous bone is more important than your cortical bone. So this bone quality is equal to bone density plus your 3-dimensional orientation of your cancellous bone. What is the volume of your cancellous bone is going to determine the success of your implants. Okay? Are you getting the difference in terminologies? So for that reason, at least for my sake, when I do my reporting, I don't follow the HU values. I follow an alternative method, and that is called as Lekop-Zaap Bone Quality Index. Now this basically is an index which gives you what type of cortical bone and what type of cancellous bone you are dealing with. It is divided into 4 criteria. So from type 1 to type 4, and you can when you see the picture, you very well can differentiate. So again, this is a subjective assessment. It's not an objective assessment, but I prefer more than the HU values which we follow. As I said, it's a DEXA scan we have to follow. So that was on bone quality. Coming on to the next part, and that is concavities. Again, if you look at this panoramic image, I want to place an implant here. I feel everything is fine. बहुत अच्छा implant में place कर दूंगा. But when I do a cross-sectional imaging, I realize that there is an absence of cortical bone here. There is a concavity here. So if I by mistake place an implant like this, I am going to perforate it. So I need a pre-evaluation of this site properly. Okay. Again, another picture of concavities where you can miss it. So you have to assess your implant imaging properly. Then there are various types of ridges which are available. Sometimes you get a rectangular shape ridge, you get a pyramidal shape ridge, you give a concavity like an hourglass shape. All these things can be very easily assessed on your CBCT scans. Coming to the most important part, and which I think is the most beautiful thing in CBCT, is that you can do a complete virtual planning of your implant. आप सब कुछ screen पे कर सकते हो, and then you can decide what dimension of implant you want to place and how it can be placed. So if you do a CBCT scan and you want to do an implant planning, I do the measurements, and then in my machine there are almost 80 implant softwares or implant companies of my choice, which suppose a doctor says I want to place a Noble Biocare or Dentsply implant, I just click in the library Dentsply implant, and then I'll get the entire dimension of height and width. From that I have to select. Suppose मुझे लगता है कि 4.5 by 8 mm का implant मुझे select करना है, I'll select that implant. That implant is virtually carried. Actually, because of the slide you're not seeing, there's an orange picture here. So that's a virtual implant. So which is carried here. Now once you carry that virtual implant there, now you can actually adjust on your screen according to your prosthetic planning and everything. And you can, if you feel no, the dimension is less, you can change the dimension. You feel the width is less, you can change the width. So everything is possible on your computer screen itself. Now just imagine this you cannot do in the patient's oral cavity. जब आप सर्जरी कर रहे हो उसके बाद आप डिसाइड कर अच्छा ये नहीं ये चाहिए वो नहीं कर दी ये सब कुछ पहले से क्लियर आपको हो जाता है. So it becomes a very easy thing. Once you do the implant planning, the next part is something called as the abutment. Now for the undergrads, do you know what an abutment is? In an implant? Not in a bridge. In an implant. So in an implant, we have a implant which is resembling a root. You want something which is going to place a crown there. Okay, for to place a crown, you require something called as an abutment. So depending upon the clinical scenario, the implantologist has to select an implant, an abutment, and has to give a particular angulation for that. So that option is also available in your software, which is there in your department, where you can select the abutment also. But as a radiologist, I don't do it because I feel it's the job of the implantologist. He knows the dimensions of the, or he knows what type of clinical scenario is. So I leave it to the implantologist rather than me doing it, but that option is available. Now please check this because this is software is there in your department. So what, this is a mandible scan for implant planning in the mandibular region. This is your Galileo software. So in the Galileo software, whenever you have a mandible scan, the first thing you are supposed to do is to trace the mandibular canal. Okay. Now this tracing of the mandibular canal will help you identify where exactly the mandibular canal is. So this is your mandibular canal here right now. So we are selecting an option here. We trace it. I don't know whether you can see this. It's a purple color canal here. And now what I am doing is the measurement. So I am measuring the width as well as the height. So suppose this is 17 mm and this is 5 mm. Depending upon that, I have to select an implant. So what after once I do the measurements, I go to the implant library. This is my implant library where there are almost 80 implant system available worldwide. Depending upon my choice, I select that implant system. See this is the implant library. And whatever dimension मैंने जो measure किया, उस dimension में fit होने वाले implants मैं select करता हूँ. And then I carry that implant virtually to my implant site here. यहाँ पे उसको मैं लेके जाता हूँ. Once I get it here, now I have to play with the software just to see मेरा implant properly placed हुआ है between the two teeth, whether it's not touching the canal, whether opposing tooth से मेरे relation में properly है क्या नहीं. Everything I can do in this software and by using the various tools which are available in the Galileo's option. So once that is done, the next thing could be either I do a freehand implant practice or I can go ahead and do a surgical guide fabrication also. So that's how you do the implant measurements in your Galileo software. You understood? Now, as I said, I think we are supposed to take a break. So we'll take a 5-minute break first. So that orientation is important, and this is for the radiologists who are going to do the measurements. Whenever you're going to orient it, see to it that the maxillary plane is parallel to your anterior nasal spine, and your postmandibular plane is parallel to the inferior border of the mandible. So that is going to give you an accurate measurement. For maxilla, it has to be parallel either to the hard palate or the anterior nasal spine, and for the mandible, it has to be parallel to the inferior border of the mandible. That is step number 1 to avoid this mistake. And step number 2 is that suppose you must have all seen the CBCT reports, right? तो उसमें slice numbers लिखे रहते हैं 35, 36, 37 ऐसे slice numbers पूरे रहते हैं. Now how are you going to replicate those numbers in the patient's oral cavity? There is no mechanism as such, right? So suppose मैंने 35 नंबर की स्लाइस में मैंने लिखा कि 10 mm बोन अवेलेबल है. जो इम्प्लांटोलॉजिस्ट जो खुद प्लानिंग करता है वो बोलता है कि मेरे 35 mm में या मेरे 36 mm में मैंने 8 mm किया, और जब वो पेशेंट के ओरल कैविटी में जाता है देयर इज नो रेफरेंस पॉइंट, तो 1 mm वो इधर भी हो सकता है, 1 mm वहीं पे भी हो सकता है, बिकॉज वी आर टेकिंग स्लाइस थिकनेस ऑफ 0.5 to 1 mm. तो 1 mm का भी डिफरेंस इधर भी हो जाता है तो डायमेंशन चेंज हो जाता है. So that is the two basic reasons why sometimes there could be a mismatch in the dimensions from the radiology report. Is it clear? Now to avoid that, we came to a conclusion, or we came that how we can make the implant practice more better, and that brings you the integration of CAD-CAM, something called as surgical guides. Your orientation option is there. Yeah, it is there inside Axis 4. So the limitation, the limitation of CBCT is that it cannot give you soft tissue information. It can only give you hard tissue information. Hard tissue मतलब bone का information वो देगा, gingiva का information bone नहीं देगा. So for a guided surgery, you require the information about the gingiva. So from where this information is going to come, it is going to come from the impression you are going to take in the patient's mouth. Okay, so वो gingival thickness आपको वहाँ से आएगा. So in CBCT, we take the hard tissue information, and in your impression, digital impression, we get the information about the soft tissue. एक बार ये दोनों डेटा मेरे पास आ जाता है, I merge both this data, the hard tissue as well as the soft tissue, and then I enter in fabrication of my surgical guide. Okay, so I am going to show you one case here. Before that, one slice I need to show it to you that even guided surgery is not 100% accurate. There could be a minimal error in this. And why this error can happen? Because of these various factors which I have listed out. There could be error at the CBCT level. There could be error at the impression level. There could be error at the integration level, or there could be an error at the 3D printing or milling error, or there could be an error at the surgical placement error. So there are 4-5 options which are there at which the surgical guides can also go wrong. But it is much more accurate than your freehand implant practice. And this is going to be your future, especially with you young generation. When you're going to pass out and go to the practice or to do implants, guided surgery is going to be the basic norms which is to be followed. So this is my one case. This is not my case. In fact, it is one of my colleague from Egypt. So here, what we generally do in guided surgery is that we do the prosthetic planning first, and ideally it should be done like that only. आप फाइनल प्रोस्थेसिस पेशेंट को क्या देने वाले हो पहले ही डिसाइड होना चाहिए, उसके बाद आपका इम्प्लांट सिलेक्शन होता है. So here what is happening, if you have a CAD-CAM machine or a milling machine from Serec or something like that from Dentsply, आप उसका डिजाइन पहले ही कर सकते हो स्क्रीन के ऊपर. अगर मुझे सिंगल क्राउन देना है या ब्रिज देना है, जो भी आप पहले डिजाइन कर लो. Then you do a CBCT scan. जब CBCT scan करते हैं, it is the same process where we do the measurements of the height and width available. Okay, so once we do the selection of the height and width available, we select the implant system. But before that, we bring in the impression of the patient. जो हम crown दे चुके हैं या crown बना चुके हैं virtually, that crown I get it into my software और उन दोनों का इंटीग्रेशन होता है. उस बेसिस पे कि वो क्राउन किस तरह पोजीशन है, देन आई सिलेक्ट माय इम्प्लांट एंड इट्स ओरिएंटेशन, सो दैट मेरा जो अबटमेंट का प्रॉब्लम आता है जो क्लिनिकली, अगर किसी ने इम्प्लांट प्लेस किया उनको पता ही मैं क्या बोल रहा हूँ, तो वो प्रॉब्लम सॉर्ट हो जाता है पहले. व्हाई? बिकॉज आई हैव ऑलरेडी डिजाइन माय प्रोसेसेस. अगर मैं उल्टा जाता हूँ, पहले इम्प्लांट करता हूँ फिर प्रोसेस के बारे में सोचता हूँ, देयर आर चांसेस ऑफ एरर. बट व्हेन आई डू उल्टा, दैट इज मैं रेट्रोस्पेक्टिवली, मैं पहले ही क्राउन डिजाइन कर लेता हूँ एंड देन आई डू द इम्प्लांट प्लानिंग, इट बिकम्स मच इजी फॉर मी. And this is where your guided surgery can come to your rescue. So what here he is doing is, he's actually done the first the measurements of the available height and the width. And now the next step, this is in your Galileo software only, we are importing the digital impression, which you have taken from the Omnicam which is there, or from the in-lab scanner which is there. तो ये digital impression अब मैं इसमें import कर रहा हूँ मेरे CBCT से software में, that is in Galileo. See this. और ये जो ऑरेंज पोर्शन है ये पेशेंट का फाइनल प्रोसेस है जो मैंने पहले ही डिजाइन कर लिया है. ओके, सो नाउ आई एम मर्जिंग दीज टू डेटा. दिस इज द सॉफ्ट टिश्यू इन्फॉर्मेशन, दिस इज माय हार्ड टिश्यू इन्फॉर्मेशन. व्हाट आई हैव नाउ, आई एम सपोज्ड टू डू, आई एम सपोज्ड टू मार्क पॉइंट्स. सो जो अगर मैंने यहाँ पे एक पॉइंट मार्क किया लैटरल इंसाइजर पे, द सेम पॉइंट मुझे CBCT पे भी पॉइंट मार्क करना. So basically 4 to 5 points I am supposed to mark so that I get a proper integration. And then I can fabricate my surgical guide. See this. I am marking the same points at the same level so that the integration is perfect. So again I'll tell you, your soft tissue information comes from your intraoral scan and your hard tissue information comes from your CBCT scans. Now see this. This is the integration which has happened. The yellow part is your कास्ट इंप्रेशन या सुपर इम्पोजिशन, और जो आप इधर देख रहे हो यहाँ पे ये, दिस इज योर जिंजाइवल थिकनेस. इतना विड्थ जो है दैट इज योर जिंजाइवा. जो इन्फॉर्मेशन हमें CBCT में नहीं मिल रही थी, अभी इंट्राओरल इंप्रेशन से हमें वो इन्फॉर्मेशन मिल गई है. व्हाई दिस इज इंपॉर्टेंट? बिकॉज आई कैन देन फैब्रिकेट माई सर्जिकल गाइड. क्योंकि अगर जिंजाइवा थिकनेस मुझे पता ही नहीं है तो मैं गाइड्स फैब्रिकेट नहीं कर पाऊंगा. So that information I have got. So once I get this information and I know this is going to be my final prosthesis, now I will going to select my implant. पहले मैंने जो आपको ब्रेक के पहले दिखाया था वो फॉर द फ्री इम्प्लांट लॉजिक, मैंने मेजरमेंट किया और सीधा इम्प्लांट सेलेक्ट किया. इसमें मैंने पहले प्रोस्थेसिस सेलेक्ट किया है एंड नाउ आई एम गोइंग टू सेलेक्ट माय, दिस इज माय प्रोस्थेसिस. तो इस प्रोस्थेसिस के बेसिस पे नाउ आई एम गोइंग टू सेलेक्ट माय इम्प्लांट सिस्टम एंड द इम्प्लांट ओरिएंटेशन. ये इम्प्लांट मेरा प्रोसेस के हिसाब से किस तरह मैं प्लेस करूंगा. सो इट बिकम्स वेरी इजी फॉर मी. जब फाइनल इम्प्लांट प्रोसेस पर इजी प्लेस करूंगा, इट बिकम्स अ वेरी स्ट्रेट फॉरवर्ड प्रोसेस. अदरवाइज इट बिकम्स अ डिफिकल्ट प्रोसेस समटाइम्स, स्पेशली इन द एंटी रीजन वेयर एस्थेटिक्स मैटर्स अ लॉट. See this. Now I am selecting the implant system. Just with a click of a button, I virtually carry the implant here. And now I can orient the implant. You can very well see with respect to my orange color prosthesis, मैंने वो implant orient किया हुआ है. So it's a very easy process which is happening for me. So that's the advantage you get from your guided implantology. Are you understanding? So once I've done this, I'm just checking whether my implant, my prosthesis is in straight alignment. It is not touching with any vital structures. It is within the bone. मैं पूरा चेक कर लेता हूँ वो प्रॉपर तरीके से. देखो मैं एक्सिस ऑफ रोड पैप, एक्सिस पाथवे, सब कुछ मैं इसमें प्रॉपर्ली रिफाइन कर सकता हूँ. दिस लिबर्टी इज नॉट देयर इन योर फ्री हैंड इम्प्लांटोलॉजी और इन द पेशेंट्स ओरल कैविटी. ये अगर जब सर्जरी प्लान करते हो आप करोगे तो वो मुश्किल रहता है. आप पहले ही कंप्यूटर पे सब कुछ प्लान कर ले रहे हो. और गाइडेड सर्जरी बिगेस्ट एडवांटेजेस, अगर ये मेरी फाइनल पोजीशन है इम्प्लांट की, दैट इज गोइंग टू द फाइनल पोजीशन इन द ओरल कैविटी ऑल्सो. देयर वुड नॉट बी एनी ट्विचिंग और वी कैन से एनी शिफ्ट इन दिस पोजीशन. अगर मैंने 11 mm का इम्प्लांट सेलेक्ट किया है, आई कैन नॉट गो 11.1 ऑल्सो बिकॉज ऑफ गाइडेड सर्जरी. इट वुड बी ओनली 11 mm. So that's the precision we get with guided surgery, which you may not get with your freehand implant planning. So that's the advantage you have with this guided surgery. So what now he's checking is just the perfect position of the implant with respect to the bone, vital structures, as well with the prosthesis. Once he's happy with this, the next step is the guide design, where we design the guide with on the Galileo software partly and partly in our lab software. So this, we're just verifying this. Can you see the implant? And this is your prosthesis. So that's the advantage you have when you have the CBCT as well as the digital impression with you. And now I design my guide. So there's a last option which is available is surgery, and then I have to just click on it. This is a report, automatic report which is generated, which I think you must be getting it from the department itself, where it gives you all the information. And then if you have a guide, you can select the guide part. Abutment, as I said, we can select the abutment part also. And you can design the various guides which are available with them. Now see this. I don't know whether you're able to see, there is something called as D1, there is something called as D2. Now, there's a basic difference in the implant kit of a freehand and a surgical guide. Freehand implant kit और surgical guide के difference है कि surgical guide का drill length is minimum 21 mm, minimum. Why? Because it has to cover the alveolar ridge, gingival thickness, sleeves. What is sleeve? A sleeve, you have stoppers in your root canal करते आप files में एक stopper रहता है. What is the role of this stopper? Just to define the same thing is the role what the sleeve follows. The sleeve is an important structure which is going to not allow your implant system or anything to go beyond a particular point, nor it will allow the shifting of the implant system or the drill when you're placing the implant or drilling the option is you're going to utilize. So that is the thing which we do it. So we are selecting the dimension of the sleeves and where it has to be placed based on the gingival thickness. ये जो space आप देख रहे हो, ये implant और उसमें जब मैं नीचे जा रहा हूँ, that space is the gingival thickness actually. वो gingiva का thickness जो हमने measure किया वहाँ पे उस पे, तो उसके basis पे sleeves लग रहे हैं. You can see this space, that is your gingival thickness which is there. Okay. So this everything you can do in your Galileo software if you have your integrated implantology stuff available in the department or in the process department. So once this is done, now I'm supposed to export this to my lab. I am having an in-lab software. Now I'm going to export this, and in the lab, I am going to design my surgical guide. Same patient. I now this goes to my prosto department if they have the in-lab, and they are going to design the guide for me. So this go to the prosto department. अभी prosto department मैंने जो CBCT planning की है वो पूरा इसमें आ जाएगा. तो ये implant है ऊपर आपका. I select the milling machine. If I am whatever MCX5 or whatever my milling machine I have, and I start designing my surgical guide. The other advantage is like every impression you take, there would be some extra material available which has come, or there would be some undercuts which everything can be cleared out in my software itself. Plus, I can select my spacer thickness, how much thickness of my surgical guide should be. If there are any rough edges, I can smoothen out. Everything you can very well do on your software itself. So this is why the blue line which I am marking is the line which I am defining for my surgical guide. कि मुझे surgical guide कितना extend करना है, whether I have to go to the entire arch, whether I have to include the palate or not, everything you can do as per your convenience. See the extra material which is there, I am just cutting it off because I don't require it. Is it interesting? So this is the planning which is going on. See this. So we have partly trimmed the model. Here also proper orientation. See this. This is the orientation. How your guide is going to fit. That axis also can be defined in this itself. Once that is done, now the spacer thickness will adjust. Can you see the white part? That is going to be my sleeve. Now this what I am doing is my adjusting my spacer thickness. 0.5 रखना है मुझे, 1 mm रखना है. ये मैं spacer thickness इस पे select कर रहा हूँ. So that spacer thickness is selected. Can you see the reduction in the thickness? It is getting reduced. The white part which is there, this is your sleeve. Okay, this sleeve is going to come within your guide itself. Or वहाँ पे अगर if you're seeing there is a window which is purposefully given. Why this window is given? Just to check when you're going to place in the patient's mouth, to check whether the fit of your guide is proper or not. Because अगर वो पूरा complete रहेगा, sometimes it becomes difficult for you to check whether the fit is proper or not. That is to be tested. So now what we are doing is, it is just a software is calculating, and now it is going to give you a surgical guide embedded with your sleeves. It will take a couple of minutes. Any question for this? It's a new thing, at least for the undergrads, but this is going to be the future of your implant practice. Maybe these steps you may not do it. It may be the radiologist and the lab which is going to do for it, but you have to know what the process is. Any questions? Because this is the last part of implants. Then you're going to move to the other sections. It could be either printed or it could be milled. Yes. No, it is happens at the lab level itself. They do it itself, the sleeves. Or sometimes you may not require a metal sleeve also. They may do it with the material itself. It depends upon your gingival thickness. Basically, it's going to be the gingival thickness which is there.
What should be the
See, generally, like in Galileo's, they have to the small, medium, and large size which is there. So depending upon we can select the sleeves options. Now see this. This is your guide which has come out. Means the software has calculated, and this is the white portion. What you're seeing is your guide. Now we just have to smoothen the guide, refine it, and जहाँ पे भी हमें window बनाना है हम window बना सकते हैं everything है ना. You can even embed the patient's name also in that. There are some software which will allow you to embed the patient's name also on that. कि कभी कभी mix ना हो जाए कि patient का है वो. तो वो सब चीजें. So this is your final guide, and you can place it and you can proceed with your implant surgery. Now in guides also there are two options. Either you can use it just for a pilot drill, or you can use it for the entire process till the last step of placing an implant. So it all depends what type of surgical guide you want to fabricate or you want to use. Is it
Sir,
clear?
sir, if there are extreme labally placed tooth or a palatally placed, in that case, can we do a block out and then make a
Yes, you
virtual
can do
block
it, ma'am.
out
In fact,
and
you can section it also. The crown you can section it also.
okay.
That you can. The software gives you the options.
What is the spacer function, sir? Spacer.
It is your design, for the guide design. Just like for our dentures, what we design the fabrication. The same thing is generally we keep it 0.5 mm thickness. We keep it for spacer. Okay, I'll skip this now. It's a lengthy video. Come to the last part. So, in conclusion, what is the role of CBCT in implantology? Your first choice of radiography is always going to be your 2D imaging, whether it's periapical or your panoramic radiograph. Once you decide where you want to place an implant, that is the time you're supposed to advise a CBCT. You just get a more information. Never over rely on two-dimensional imaging because it can go horribly wrong. So always use the help of 3D, and the future is integrated implantology. Guided surgery is going to be the future, at least for the next 5 years. And it is going to be accurate. In fact, it is going to be more accurate. So this was all about the role of CBCT in implantology. Now we move on to the next cases, and these might be few interesting cases for the undergrads. They would enjoy seeing this. And that is CBCT in surgery. It's not working. Okay, so where are you going to use CBCT in surgery? So basically, you can use it for impactions. You can use for your cyst, tumors, malignancies. So all these are the indications and fractures where CBCT can be used. I'll be showing you cases. The first indication is impacted molars. Again, as I say, your first line of radiographs would be periapical and panoramic radiograph. On your panoramic radiograph, if you feel that the roots are approximating or you're not getting a very proper information about the anatomy or the relation with the canal or the sinus, that is the time you can very well advise CBCT. So what is CBCT going to give you? It is going to give you a three-dimensional picture of your entire tooth, your relation with the canal, with the sinus. Like in this case, this is again done on your side axis. All my videos which are there are from side axis itself. So you can very well use it, this thing. In side axis, you can go into the patient's jaw. Yeah, can you see it? So here what you're seeing is I wanted to evaluate the impacted third molar. So this is possible in a side axis. You can go inside the bone. You can come out. Now all this thing you cannot do in the patient's mouth. आप patient को ऐसे ऐसे घुमा नहीं सकते. Everything is possible in 3D. आप सब कुछ आराम से देख सकते हो. You can see the roots, how it is aligned, what is relation with the mandibular canal. Everything can be very nicely seen on your CBCT scan. So यहाँ पे what information the radiologist has to give you, she or he has to give you the information. What is the orientation of the tooth? How many roots are there? What is there any variation in the anatomy? And what is the relation of the roots with the canal, with the sinus, or any other findings which is important for the surgeon to know. So all these things are possible with your CBCT. This is one case, I think, too bright. There is actually a bifid mandibular canal which is there. This is one of my student in college. So on the OPG, we realized that there was a bifurcation of the mandibular canal. So for that, we advised a CBCT scan. Can you see the bifurcation there? So that we color coded it. We realized that it is going towards the distal and buccally. So that information was passed on to the surgeon. If you give this much information to the surgeon, it becomes very easy for them to extract, or just at least beforehand they can, whatever complication has to be there, that they will can advise the patient that this is the possible complications which are there. This is another case of multiple impacted canines and molars. Now, whenever there's a canine which is impacted, there is always a question whether we have to go for an extraction or we have to do an orthodontic treatment. So all this information can be very well seen on your CBCT scan. Like where is exactly the position of the tooth, then how many roots are there, what is its relation of this canine with the central and the lateral incisor, what is its relation with the incisor canal, with the nasal cavity, with the sinus, is there any resorption there, is there how much amount of bone is there surrounding the tooth. Everything is possible to get an information with your CBCT scan. Now these all sort of images, see, you cannot get it on your panoramic radiograph. इसमें क्लियर कट आपको पता चलता है कि वो रूट देखो एंटीरियर वॉल से आ रहा है. इट इज along the, you have heard about something called a line of Ennis, पढ़ा है ना? You can very well see on that exactly the position of the root apex and everything. It becomes very easy. This is the same patient. This is a clinical picture. We extracted this tooth. For the upper, we went with the orthodontic treatment. Now this is an interesting case. Can anyone tell me what is the problem with this panoramic radiograph? This is one of my earliest cases. I think this is 2016 ka mera case hai, and I showed you in every presentation. It's a very interesting case. Now basically this dentist of mine is a friend. He was attempting a root canal for tooth number 11. So when he took an RVG, he realized that there is a radiopacity in the periapical lesion. Periapical lesion के अंदर एक radiopacity है. So for that we took an OPG. In the OPG we realized that there is a shadow which is here, okay, which is not looking normal. So for that, for interest purpose, we did a CBCT scan. So what we realized was that there was an impacted supernumerary tooth. It was invertly placed and the root apex was actually superimposing with the periapical lesion. I think there is an oral surgeon PG here. ना oral surgery कौन है यहाँ पे? हाँ, अभी मैंने what's your name? डॉक्टर देवाशीष को बोला भाई ये ओपीजी है, ऊपर दांत है, अभी निकाल। तो देवाशीष क्या करेगा, पहले वो ढूंढते रहेगा। पहले तो ओरल मेडिसिन पीजी को पूछेगा भाई बक्कली है क्या लिंगुअली, पहले पैलेटली बता दे। स्लॉब रूल फॉलो कर लो, स्लॉब रूल से जितना इन्फॉर्मेशन मिल सके निकाल लो, नहीं तो फिर एक्सप्लोर करते जाओ। सो द अमाउंट ऑफ मॉर्बिडिटी ही इज गोइंग टू कॉज टू द पेशेंट इज हाई. That can be avoided with your CBCT scan. Why? Because in the CBCT scan, I am going to tell you exactly at 10 mm in this location, just open up and you can see the root of the tooth. So the amount of destruction he can cause in the adjacent structures would be eliminated. Are you getting me? Why? Because we are getting life-size images from this. So that's the advantage. You have to use it for your CBCT purpose or your cases with impaction. Again an interesting case, very easy case in fact for oral surgeons. There was a vertically fractured tooth 6. So the dentist, a colleague of mine, attempted an extraction. So when he attempted an extraction, one of the root piece slipped into the sinus. Okay, so in this we realized they slipped into the sinus. So we went, he sent the patient to me. So we did a first CBCT scan and then another CBCT scan. Now this is another feature, I don't know whether you are aware, that the Sidexes allow is that you can compare CBCT volumes at one go. Do you know oral medicine PGs? किया क्या 3 साल में? This is a feature which is there where you can compare your pre and post scans. Now in this case, these are 2 scans which we have compared. This is the first scan, this is the second scan. So if you see, earlier scan में root piece यहाँ पे थी और second scan में root piece went up till the orbit. Okay, now again, because I'm a radiologist, I'm having software. You also have a Zelis software. Us Zelis software, there is an endoscopy tool. You know it? There is an endoscopy tool there, and that endoscopy tools allows you. See, in today's time, oral maxillofacial radiologist को techno savvy होना बहुत जरूरी है. बहुत से सॉफ्टवेयर आते हैं और आपको उसका खेलने का मजा आना चाहिए. Now this is an endoscopy tool which is there in your Zelis software. और उस सॉफ्टवेयर से हम we went into the sinus and we located precisely that root piece at what dimension it is and at what level it is, and then we gave this information to my surgeon and then the surgeon removed this root piece. Have you seen what is the indications, how it can be used? Okay, very simple case tha, but it turned out to be a very complicated case for the implant to the surgeon. This is another case, maxillofacial trauma. Again, as I was saying you, field of view आपको select कैसे करना है. Now this was a case of a zygomatic complex patient. मुझे mandible नहीं चाहिए था. I selected 11 by 10 का FOV and then we did a CBCT scan, and in the CBCT scan we can see it. And again comparative feature ये दिख रहा है. दो scans मैं साथ में compare कर सकता हूँ. अभी जब जाओगे देखो वो. You can very easily compare it. See this. This is one fracture here and fracture here. ठीक है? What is this? Oral medicine PGs मत बोलो, दूसरा वो. Undergrads, very easy. Patient swelling आती है floor of the mouth पे खाना देखते ही. Yeah, this is a salivary stone which you can see this very clearly. You can see on your CBCT scans. Yeah. What is this? It could be a cyst, it could be a tumor. Okay, basically gentigerous cyst. You can very well see the thinning of the anterior border, bicortical expansion, mandibular canal getting involved, tooth getting displaced inferiorly, inferior border of the mandible thinned out. Very nicely you can see. Just you would have seen on a CT scan, you're seeing much clearly on your CBCT scan. Again, this is a case of a multiple cyst. See this. There's a cyst here, there's a cyst here, there's a cyst here, there's a cyst here. Can you see multiple radiolucencies? Here also you can see. So very nicely, without any superimposition, you can see these cases. Any undergrads? What is the diagnosis? multiple tooth-like structures. Odontomes, good. So this is the case. You can actually count the number of tooth here, the odontomes which are here. Now this is one thing. My oral medicine PGs can collaborate with the oral surgery PGs and work on a prostho PGs and work on this. Is how to use CBCT in malignancy for your patient education purpose. This even I didn't know. I when I started, and then one of my oncosurgeon colleagues, they started advising CBCT. Then I realized why he's doing it. So in CBCT again, even if there's a patient with malignancy here, I can see there's a malignancy here pattern which is there. I cannot define completely how much is the destruction, what structures it has involved. So for this, it is always better to do a CBCT scan, because CBCT scan is going to tell me the amount of destruction, where exactly is the destruction, what is its relation with the canal, everything can be nicely defined on this. Now on top of this, what we do is, we do a CBCT scan, then there is something called as STL conversion, which, why this STL conversion is required, because हमको 3D printing models जब करने रहते हैं, we're supposed to have an extension called as the STL. So that conversion we do it, we print the 3D printed model, and this the oncosurgeon use it is for patient education as well as for his planning. कहाँ पे कट करना है, कितना डिस्ट्रक्ट कट होने वाला है, everything he can do it. So this is again another indication which you can use, or you can collaborate with your colleagues and do it, because you are having a CBCT machine here. TMJs, very regularly we have cases. Now this is a case of ankylosis. This is a false ankylosis. Can anyone tell me why? Why not a true ankylosis? Why a false ankylosis? Because you can still see there is some space which is there between the glenoid fossa and the condylar head. It's not completely fused. It's basically a false ankylosis. See this. दिख रहा है gap? Bifid condyle. देखा था अभी तक कभी? This is a bifid condyle. But this is basically anatomical variation, or sorry, not anatomical, but basically this could be because of trauma. Why? Because you're just showing one glenoid fossa here. Generally, if it is anatomical, you might just see it two glenoid fossa. Trauma, subcondylar fractures, very nicely you can use it for CBCT. Arthritis, you can see the flattening of the condylar head. Then this is another case. He's my colleague who regularly, he was a TMJ specialist. Again, we use this feature of comparison very regularly on our side axis, pre and post. And this is actually an open close and close, open position and close position 3D scan. आपके 2D scan में होता है open and close TMJ, right? You can do it on 3D also. And you can then compare it in different views, sagittal view, coronal view, axial view. You can very easily use it. Then COVID, post-COVID, we had multiple cases of mucormycosis. Again, selection of right field of view. Again, 11 by 10, you can easily use it. And can you see the difference between the two sinuses? There's a gray shadow here. This is healthy sinus, black. You can see irregular destruction of bone, just like mimicking an or malignancy or mimicking an osteomyelitis pattern. Okay, so these were classical mucormycosis cases. You can also see the osteometal complex here. यहाँ पे ये obliterated है. This is patent. Okay, so very easily this could have been identified on these scans. Now I want the undergrads to diagnose this thing. Oral medicine PGs can keep quiet. What is this? A pathology below the mandibular canal. This is Staphney cyst. इतना सुंदर कभी देखा था? So you generally see on a panoramic radiograph. अगर आप देखोगे, try seeing a panoramic. This is on a 3D. You can clearly see, and you can see the difference in the lingual cortical plate. यहाँ पे देखना अभी. You can actually see the concavity which is there. See the beginning of the concavity which is. Can you see? यहाँ पे canal है और ये नीचे पूरा आपका defect है. So this was in oral surgery. Any question? You realize where the indications are? Okay, so you should start sending the patients now to the department. Now coming to the most interesting topic which I like is endodontics, because there are some really interesting cases day to day we see, and because lots of variation in your canal anatomy. Learning from others' mistake is wisdom, and waiting to learn from your own is ego. And this is very much true with endodontics. Now this gentleman was trying a root canal for upper 6, but he, instead of filling the palatal canal, he filled up the bifurcation canal space. So this enter into the sinus, and you got a entire sinus infection because of this wrong filling. But till date, since 2011 I am doing my lectures, till date I have not seen a more complicated case like this. This gentleman painted the entire mandibular canal with his root canal peeling material, in fact. Sealer, in fact, it was a sealer. And this is a case from Bangalore. I got a call from the diagnostic center that this patient had done a root canal yesterday and he is having a burning sensation. So when we did the CBCT scan, we realized the entire mandibular canal was filled up with the sealer material. Now again, remember my earlier slide where I said 30% of bone loss is required before it is actually seen on a radiograph. Nothing like that on CBCT scan. The advantage of CBCT scan is, at least in this patient was a chronic patient, having an infection which was very chronic. So because of the chronic infection, the entire mandibular canal was eroded earlier itself. Okay? So when the dentist pushed the sealer, it went just through the apical foramen and entered into the sinus. And this we could very well see on the CBCT scan. This becomes difficult to be visualized on your conventional imaging modality, but on CBCT you can very well see these things. So whenever you're seeing scans, see the finer structures, finer details, because they would be very important for your diagnosis. So where are you going to use CBCT? You are going to use CBCT wherever you see there is a variation in anatomy. And one of the variation is MB2 canal, and the other variation would be so that is the clarity of scans you get in your 5x5 volumes if you select the proper field of view. यही scan अगर मैंने 8x8 में लिया होगा तो ये आपको इतना clarity नहीं आएगा. So again I'm telling you, whenever you're sending your patients, write the indication. It becomes very easy. This is another case. Just look at this picture. It's a nightmare for an endodontist. Itna canal variation pura. Now again it becomes difficult to diagnose on your convention. Either you have to have an endodontic microscope or you have to take a CBCT scan to understand in the variation in this anatomy. So again this is possible with your CBCT scans. This is a case of a re-RCT where the dentist, patient wanted a re-RCT, so my dentist advised a CBCT scan for 4/7. Sorry. Yeah. So for 4/7, this for re-RCT. So whenever you're doing endo cases, at least for the radiologists I'm telling you, always use the axial images. Axial images are the best images for visualize for endodontic purposes. Okay. So what was happening in this is, you could see the two canals, right? There is a mesiobuccal and a mesolingual canal. Just look at this image. You can see mesiobuccal, you can see distal. You're not seeing the mesolingual. But when we are going down, we can see the mesolingual canal. There. Very close to mesiobuccal. The coronal portion of the canal is not visible, but from the middle and the apical 1/3 it is visible. So that was diagnosed very nicely. Again, a 3D tool, you can use it for your purpose, just to see the anatomy of the canal properly, like this. You can see the mesolingual canal here also. So we gave the proper anatomy to the dentist. We told him what is the working length, total working length, and with the help of that, he was able to do the proper biomedic BMP, and he can also do a proper, this is a post-op image, in fact, with the master cones. And this is one tool which is available in Galileo's, which you can use it. Especially you can do a study on this, whether the measurements coming from the Galileo software and your apex locator is precise or not. There are already studies, some published in JOE journal, which they have compared this and they found out this measurement of the working length is accurate on a CBCT images as with your apex locator. But that's one tool which is available, where if you want some time to know the working length, you can do it on CBCT scans also, if you don't have an apex locator. Next is your perforations. So first was your variation, MB2 canal and any missed canal. Now this is a very interesting case. This is one of my senior practitioner in Bhopal, 25 years of history of dental practice. He was attempting a central root canal. अब मैंने 15 साल से हाथ नहीं लगाया हुआ एरोटर को, बट आप मुझे बोलो कि सेंट्रल इंसाइजर का रूट कैनल करने को मैं कर दूंगा. आई एम दैट मच कॉन्फिडेंट. दिस जेंटलमैन हैविंग अ मोर एक्सपीरियंस ऑफ 25 years, 5 बार उन्होंने फिलिंग किया, 5 बार पेशेंट को पेन हुआ. After that, he advised a CBCT scan. The first slice when we saw it was perfect. ठीक ही लग रहा है, कुछ problem नहीं लग रहा है. But when we started using the software, then we realized that there was a perforation which was created earlier. Can you see a channel there? So that was a perforation which was created in the beginning itself. Now this was diagnosed only because of CBCT. On a conventional imaging modality, you would not be able to diagnose these things. Are you getting me? This is another picture of just a perforation. See this. Can you see here? This is a classical perforation there. Have you seen any perforation cases in your department? देखिए cases अपने आए एंडो के लिए सब स्माइल कर रहे हैं कुछ जवाब ही नहीं दे रहे. You should start seeing the scans now. जितने भी आए हुए scans देखो. You would see such findings. The next thing is periapical lesions. I'll just show the videos. Can anyone tell me the diagnosis of this? What is the proper diagnosis? ये देखो यहाँ पे. It's a radicular cyst. Okay. So when you're seeing this, you can see the eggshell crackling. सुना है? देखो ऊपर कितना thin है वो cortical plate. It's punctured partly. And its relation with the incisive canal, its relation with the adjacent teeth, everything you can very well see on your CBCT scans. The next is your trauma. Again in trauma you can do it. See this. Can you see the fracture line here? Okay, so whenever patient is having a history of trauma, you can go ahead and do a CBCT scan. Now, this is one thing I've discovered, or you can say found out for almost 4-5 years now. There are times when the doctor will send the patient to me to do a CBCT scan. When I ask him why you're doing the CBCT scan, he said there is nothing in the mouth, but still the patient is having extreme pain. So that's where we do a CBCT scan, and I would like to see you to check these things. Can you see these micro cracks? These are the probable causes of your pain. And this you can check by, at least for the radiologist I'm telling you, you have to adjust the window level. अगर आप ये देखोगे आपको लगेगा ये स्कैन तो बहुत गंदा है, बट ये गंदा स्कैन नहीं है, मैंने उसका विंडो लेवल एडजस्ट किया हुआ है. आई मेड इट मच मोर डार्कर सो दैट माय कंसंट्रेशन इज जस्ट ऑन दैट टूथ, नथिंग एल्स. ये देखो ये एक्चुअल उसकी क्लैरिटी है. So whenever you have such patients, always for micro cracks you can detect. Now again this comes a question from the endodontist. वो बोलते हैं कि हमको लग रहा है फ्रैक्चर है, आप डिटेक्ट नहीं कर पा रहे, आपकी मशीन खराब है, डेंसफ्लाई की मशीन खराब है, उसमें दिखते नहीं फ्रैक्चर्स, उनकी मशीन अच्छी है उसमें फ्रैक्चर दिखते हैं. Please try to understand the lowest resolution which is available is 79 microns in that machine. So any fracture which is below 79 microns will not be detected. Okay, anything above 79 microns would be detected in this machine. Anything below 79 microns cannot be detected. So उस रेंज में है तो दिख जाएगा. This is another case. Just look here. Can you see a line here? This is your fracture. Check here. दिख रहा है यहाँ पे? The cortical plate is gone. So this is basically a 10-12 fracture which was there. This is another case of a fracture. See here. Can you see a line here? This is again a case of fracture. Yeah, now this is very interesting thing for my radiologist, where sometimes they might diagnose an artifact as a fracture. Now, and this is much more common with your root canal treated tooth. In a root canal treated tooth, there are chances that sometimes if the patient doesn't have a crown, so there he might just overbite it or extra bite was applied and there could be a fracture. But detecting a fracture on a root canal treated tooth, it is a tough job. And sometimes we radiologists also do mistake, and sometimes when there's no fracture, we say there's a fracture. Why? Because the root canal filling material throws an artifact. एक artifact ऐसे throw करता है कि वो fracture line को mimic करता है. If you have ever seen the CBCT scans with root canal filling material, तो वो प्लस साइन की तरह दिखता है. मतलब फिलिंग के अराउंड आपको एक प्लस साइन दिखेगा ब्लैक लाइंस ऐसे. तो ऐसे लग रहा है कि अरे इसको तो पूरा फ्रैक्चर है. But that's not a fracture, it's an artifact. So as a radiologist, I'll give you a tip how to find a fracture line. This easiest thing is, when you're looking at these images, wherever you feel that there is a breach in the pedal space, suppose axial image में आपको एक point पे लग रहा है कि अच्छा इधर breach लग रहा है, go to the next image, go to the sagittal image or go to the cross sectional image and check at the same level. अगर वहाँ पे breach है in the same place, that it is 100% it's a fracture. If that breach is not there in the other images, that indicates it's an artifact. But still, there are high times sometimes we may do make mistakes in that. So the best thing is to refine and develop a learning curve, ताकि आप जितने images देख पाओगे आपका experience ज़्यादा हो जाएगा और आपको diagnosis बहुत easy हो जाएगा. But overall, the diagnosis with CBCT with root fractures in root canal treated tooth, it is tough job. Calcified canals, again, very nicely you can find out CBCT scan. See the canal patency here, it is completely obliterated here. Then if you are using guides, now there are guides for endodontic purpose also. For access cavity preparation also you can fabricate a guide, and for endodontic surgeries also, especially in the molar region, you can fabricate a guide. Why? Just with the help of CBCT scan, आप CBCT scan लो और guide design करो and you give it to your endodontist friend, and he will do an access cavity based on that, or he can do a periodontal endodontic surgery with it, because it's a three-dimensional picture which is available. So have you seen the cases? You have understood the indications now. Any variation like MB1 to MB2 canal, missed canals, or you have any variation in anatomy, go ahead, do a CBCT scan. Trauma, periapical pathologies, cyst, tumors, fractures, you can go ahead and do a CBCT scan. Don't rely on your conventional imaging, because sometimes they may give you a misdiagnosis. The next indication is periodontology. Again, because these are life size images, आप accurate measurement कर सकते हो CEJ से कि कितना bone loss हुआ है. Percussion area is sometimes difficult to diagnose on your panoramic radiograph. It's very easy to diagnose on your CBCT. See this. You also know what type of bone loss is this, horizontal type of bone loss, how much is the bone loss. Everything can be accurately measured. Achha, one thing I missed actually, and this again for endo purpose, and this is common with your first molar and the second molar. Whenever there is a chronic infection in the root apex, there are high chances that it will erode the floor of the sinus. See this, आप देख लेना आप जाके scan. So जब eroding होता है, you will see this grey shadow at the floor of the sinus. Some people will misdiagnose this as sinusitis because of sinus problem. No, it's not because of sinus problem. It is because of your odontogenic infection. आप इसका root canal करो, ठीक करो, वो automatically resolve हो जाएगा. So that's your job as a radiologist to tell that. So ये जब आप देखते हो, and this is classically with 6 and 7, maxillary 6 and 7. So go back, see your scans, and see the variation in the or changes happening in the sinus. You can very well see it and do it. This is another case of a periodontal abscess. On a periapical radiograph, there was a radiolucency here. So we did a CBCT scan just to check where the pathology is and how much is the defect. This was the tooth. Can you see the radiolucency here? This portion. So that was the defect. It is important to us as a radiologist to tell them what is its relation with the incisive canal, whether that pathology is approaching the canal or not, incisive canal. Because if it is, you have the surgeon has to know about it. See this. This is the clinical picture, and you can see the defect here properly. So this was imperio. Coming to the last part, orthodontics. You can use it for age assessment, for facial growth, for any variation in the disturbance tooth eruptions, and airway function. Do you have Dolphin software here? So there must be 3D analysis also. Are we doing it, 3D analysis? If not, you can do it. No, but why I'm stressing this, I need to know the accuracy of the 3D CBCT self analysis and 2D. Whether 2D analysis which we all are doing on the lateral self, is it more accurate than ideally 3D should be more accurate. because right and left we are going to do separate analysis. So what is the final outcome of the 5 years, that is there, but the option is available where now you can do your self analysis on a 3D mode on your CBCT, and right side could be different analysis, left side could be different analysis. So that's one thing which is there with your self analysis you can do. You can assess the impacted canines, which I already told you. This is one of my case where this girl had an impacted canine. So after CBCT and giving the information to the orthodontist, this is the post-op pictures which is there. Root resorption, again a very important thing from the orthodontist point of view. After post-orthodontic treatment or during orthodontic treatment, they need to know where the resorption has happened. On panoramic radiograph, on a periapical radiograph, you cannot tell where the resorption is happening, whether it's on the buccal side or the lingual, labial or parietal. But on CBCT, you can very well tell where the resorption is and how much resorption has happened. Like in this scan, this is a 3D picture, I'm just showing it to you. Now when you click on the axial image, can you see the radiolucency here with the central incisor? That's your resorption which has happened. Okay, this becomes very difficult to diagnose on your conventional imaging. Then there is one case of ankylosis. I'll just show it to you. This is ankylosed tooth. See this. It is fused till the nasal floor. There is no pedial space visible. It's complete bony fusion with your nasal cavity or nasal floor. Again, very interesting. You can give all the information to your either an orthodontist or the surgeon if they want to remove it. There is one thing which we can develop, and this is a dental institution, age assessment. You generally do the age assessment by hand wrist radiograph, right? किया हुआ है पीजीज ने, हैंड wrist से हमारा preclinical work है ही इसमें, ठीक है? So age assessment can be a 3D option, but you can use it on a 2D option. You can do it on 3D. I have developed a patented a bite block for the hand wrist on CBCT. अगर आपके मशीन में बाइट ब्लॉक्स है, राइट, उसी में हमने एक डिज़ाइन किया हुआ है जिसमें हम हैंड wrist रखते हैं, and we get a 3-dimensional picture of my hand wrist, and I can do an age assessment 3-dimensionally. हम जो कर रहे हैं वो 2-dimensionally कर रहे हैं, इसमें हम 3-dimensionally, and these things should come out from the pages. थोड़ा एक्सप्लोर करते रहना चाहिए सॉफ्टवेयर के साथ. The last indication and one of the most interesting indication is airway analysis. Airway analysis for undergrads, in a simple term, जो पेशेंट को स्नोरिंग का प्रॉब्लम है उस पेशेंट्स को हम CBCT स्कैन कराते हैं just to check whether his airways is patent or not. Now please try to understand, airway analysis gold standard is polysomnography test. It is not CBCT. CBCT is just to evaluate your airspace, whether airspace is patent or not. Sleep apnea or snoring can be cause of multiple problems, not only airways. It could be caused because of macroglossia, short neck, or it could be because of your jaw alignment, whether it's maxilla mandible is how it is positioned. CBCT will just give you how your airspace looks like, and if there's any constriction, where is the constriction and how much is the constriction. एक बार जब ये पता चल जाता है, there are two options. Either you do the treatment prosthetically, एक appliance देके advancement placement देके you can just open up the airspace, or you can do an orthodontic surgery, or it is possible that you send it the patient to the sleep clinic or to an ENT surgeon and he takes care of your patient. As a dentist, there are two options available. One is the prosthetic option and the other is an orthodontic option which is available. Like in this case, the red portion indicates that there is a constriction, or that would be the probable cause of snoring or reduction in the oxygen level when the patient sleeps. So this is your pre-scan. Now this is a post-scan after doing the prosthetic treatment. Advancement option appliance dene ke baad, we have opened up the airspace. Okay. So this video is now going to show you pre, and this is the post video where it is going to show you how the advancement has caused the opening of the airspace. ये जो narrow constriction दिख रहा था पहले वीडियो में, अब ये open up हो गया है. So now that portion becomes green. So please try to understand, CBCT is just going to give you an information about your airspace. It is not going to conclusively tell you that this is the probable cause of your sleep apnea. So your test remains polysomnography test, because sometimes people mistaken it कि अरे ये sleep apnea है, CBCT पे आ गया तो sleep apnea है, ये आपको ये है. But there are multiple causes for it. We just cannot rely on CBCT for it. But it is one of the indications. I don't know whether you have this software. You have CCAT Air? Okay. So that is, this is CCAT air actually. So in that you can, but I think in Zealous it is there, but that's a tedious job in Zealous one. So this is just with the click of a button you can segment your entire sinus. This, like this, and then we can do the color coding part immediately. See this. Now see, this entire portion is green. The earlier portion was red. Okay. So after treatment, it has come out green, and you can see the entire airspace. You can see the volume, how much is the width. Everything can be calculated on this. See this. And then you can compare it also, pre and post simultaneously. See this. Now you're going to compare with this option. I can compare both the things. See this. Okay, so it's an interesting tool to show the patient how the improvement has happened. Can you see the constriction here? See here, it is opened up. Okay, so this is the airway analysis by a CBCT software. Have you understood? Okay. Coming to the last part, and what is the next thing? What after 5 years in radiology is happening, especially with respect to CBCT? So the first thing which is already there, and this is called as dynamic navigation system. I have already told you about surgical guides and implants, but that is static. Static का मतलब है आप implant डालोगे, वापस CBCT करोगे, फिर पता चलेगा कि भैया आपने डाला है बराबर implant है कि नहीं. In dynamic navigation, real time like robotic, you can actually see your implant going into the bone site or the implant site. Why? Because it's the CBCT place which is there. So that would be a unit which will be fixed on your dental chair. आप CBCT scan का load रहेगा और जैसे उसके wires रहते हैं जो robotic wires रहते हैं, and when you're placing the implant on your screen itself, you can see your implant going inside the bone. So that's the next big thing which is there, and that's the dynamic navigation system. Second is the artificial intelligence. We are working on artificial intelligence. I'm an R&D head for a CBCT company in US, where we are developing an artificial intelligence software where आप आपका periapical या bite wing या CBCT या OPG आप upload करोगे, immediately the AI will give you the diagnosis. Okay, so that's the other advancement which you are going to see. Plus we can segment the jaws. आपको एक single tooth segment करना है, अलग से रखना है, हम वो कर सकते हैं. Maxilla को separate करना है, sinus को separate करना है, airways को करना है. Everything is possible with your artificial intelligence, and it is going to be playing a big role in maxillofacial radiology, like this. You can get the single section images with diagnosis. इसका यहाँ पे नीचे diagnosis लिख के आएगा. Compus tooth का क्या problem है? Everything can be done with the help of your artificial intelligence. So this is the future. There are problems. I am not saying CBCT is a perfect tool, but the biggest problem is that it is very poor in your soft tissue. I already told you that जैसे gingival thickness is not going to come on it. Okay, so for undergrads this is important, because आप जब clinic open करोगे और आपको लगता है कि patient को swelling आया, तो बोला जाजू सर ने बोला था swelling है, CBCT करो advice. पहले identify करो what is the cause, whether it's an odontogenic infection or a non-odontogenic infection. If it's an odontogenic infection, fair enough, do a CBCT. But if it's a non-odontogenic infection, don't do a CBCT. Why? Because CBCT is poor in soft tissue contrast. उसके लिए आप MRI करो, ultrasound करो. Same thing with your internal derangement. Internal derangement में अगर disc का problem है, TMJ disc का, don't do a CBCT, do an MRI, because the MRI is going to give you more information on that. So you should pick and choose your technologies which is required. I didn't think about, there is a lack of accessibility in Nagpur at least. Nagpur has sufficient amount of CBCT machines across the city as well as in the private sectors and in dental colleges. Cost, wherever, as you have seen all the cases now, and I always feel there's always a benefit from CBCT. You get more information which may not be there on your CT scans or your panoramic machines. So what is your take home message? Your take home message is that today you have learned a new technology. You have understood what is this technology and where you are supposed to use it, and why you should use it. Because dentist पे हमेशा एक इल्ज़ाम लगता है कि dentist बहुत महंगा है, बहुत charge करता है. Okay, that is always the blame which we get. Okay, but we have to explain the patient dentistry per se is not expensive. It is a repeat treatment. जो retreatment रहता है ना वो expensive रहता है. So if your diagnosis is proper, you have used the right imaging modalities and done a proper treatment plan, then dentistry is a cheaper thing. It's not an expensive thing. But you as a radiologist, young generation, you have to understand this technology because जिस तरह 60s, 70s, 80s में OPG regularly practice में आ गया था 90s में भी है. CBCT अभी 2000 के बाद रेगुलर प्रैक्टिस में है. तो आपके पास कोई ना कोई पेशेंट आएगा दूसरे से रेफर होके जो एक CBCT लेके आ जाएगा या रिपोर्ट लेके आएगा और बोलेगा सर अब ये देखो मेरा ट्रीटमेंट कराओ. तो यू शुड बी वेल वर्स हाउ टू यूज द CBCT थिंग, how to use the software, how to interpret the images. That is important for you. So you young generation have to learn CBCT. So this is my book. If you want to further read, I just whatever I was able to explain, I've explained. But that's one book of CBCT where you can we have explained everything right from basics, anatomy, everything is there. I'm the editor of CBCT magazine, which is an official publication of CAI Academy. So that's also regularly we publish articles quarterly. If you want to send any articles, you can very well send to us. I once again thank the Dental College as well as Dentsply Sirona for giving this opportunity. Thank you very much. This is my email ID. If you have any questions, you can mail me. Thank you. Now, this is the last picture I've kept, and I want the undergrads to know this. You know who is this? Professor Stuart White. White and Farrow book है, उसके author है वो. And the next gentleman below that is Professor Alan Farman. He was the biggest. He's retired now. My biggest name in maxillofacial radiology. और मैं दिख रहा हूँ एकदम पतला सा. So that happens in 2010 when I passed out my PG. I went to Istanbul for my first international conference. First, उसमें मैंने paper present किया था. And वहाँ पे सब CT दुर्रम खान, CT, MRI, OPG, CBCT पे कर रहे और मैं जाके वहाँ पे lingual vascular canal, periapical radiography present करके आया. So these two gentlemen were very very kind. In fact, Professor Stuart White तो 7 feet से लंबे हैं, but is very very soft gentleman. So these two gentlemen stressed me that you are having a passion for radiology. Do radiology. Don't follow your oral medicine. अगर आपको नहीं इंटरेस्ट है मत करो. आपको रेडियोलॉजी में इंटरेस्ट है तो रेडियोलॉजी करो. एंड जब मैं वापस आया, आई गेव अप माई क्लिनिक एवरीथिंग एंड आई स्टार्टेड माई एक्सक्लूसिव रेडियोलॉजी प्रैक्टिस. दैट्स हाउ माई जर्नी बिगैन. सो द आइडिया ऑफ टेलिंग यू इज फॉलो योर पैशन. आपको जो इंटरेस्ट लग रहा है कि देखो ओरल मेडिसिन कोई बाई चॉइस सब उठाते नहीं है. ये तो मुझे पता है. मेरा फेवरेट सब्जेक्ट पेरियो था, मुझे पेरियो मिला नहीं पर मुझे ओरल मेडिसिन मिल गया. बट आफ्टर 15 years आई एम वेरी वेरी मच हैप्पी विद वॉट एवर आई हैव because I started liking it and then whatever I wanted I followed it. So same thing with you all. You may not like oral medicine at this go, but कभी मिल जाता है, explore it because in today's time, trust me, oral medicine people are the eyes of the entire dental fraternity. आप कोई भी टेक्नोलॉजी उठा लो उसमें CBCT आएगा और उसमें डेंटल रेडियोलॉजिस्ट आएगा ही. So that is the biggest boon dental radiologists have in today's time. But it is up to them PGs to learn that. मशीन होने से फायदा नहीं है. मशीन से सीखना ज़्यादा इंपॉर्टेंट है. मशीन लगा के कोई मतलब नहीं है. यू हैव टू एक्सप्लोर एंड यू हैव टू यूज दोस थिंग्स. ओके, सो इफ यू हैव एनी क्वेश्चंस यू प्लीज आस्क मी.
Hello.
whenever some interns were posted or some PGs, anybody who's coming, whenever I had seen a case, uh, I thought we should be shared with interns or something. So whenever we got a patient or any with a disease or with the variations, I we used to show to that particular batch. Probably many of the interns or students might not have seen, but few, at least few of them, they have seen some variations. For example, that staphnous cyst that was shown to a batch. Okay, so those who were posted, they they have seen it. Okay, so that is, so we don't know whenever which patient comes and how to have it. Okay, so this is one thing. Another thing, now Dr. Jaju has explained very nicely. Lot of, you have to go into depth. Okay, so go deep and deep. Evaluate a radiograph. That is very important. Unless, say, unless and until your mind doesn't know, your eyes cannot see. So you have to have a knowledge of variations, normal anatomy, pathologies, then yes, your eyes will definitely pinpoint a disease or any abnormality or any variations. Sir has already said that anterior mandible, okay, lot of variations. Yes, similarly, maxillary anterior region is also having lot of variations. Okay, lot of canals are there also. So that is again, so we are thinking that anterior portion is very much easy for implant placement. No, before going for implant, go for the CBCT, see the canals. There are a lot of things which are there, and definitely it is not there. On one side there will be variation, another is a normal thing. So that things are also there. So you have to go for this CBCT for accurate finding out or evaluation of your structures. Okay, so each person is different, okay, in its normal anatomy and variations. So you cannot say on the your 2D you see two laminar duras. Okay, so all these things you have to see curvature, accessory foramens. Okay, so all these things, you, unless and until you read, grasp normal anatomy, variations, and then seeing it on the radiogram. So your mind should know first what are the things, then definitely your eyes will identify the variations or abnormalities. Okay. So with this, I definitely thank Dr. Prashant for an excellent presentation, okay, which is beneficial for all of you. Okay. Thank you.
Scan. So I think basically by in 11 by 10 you'll require a scan, and it also for zygoma, yeah, that is more than enough. That is more than enough. It varies, beta. The every lab charges differently. It depends.
Anybody who wants to have some information, any questions, any?
The guided navigation. So in the guided navigation, you said there would be continuous imaging of the implant placement. So what about the exposure in that case? Exposure, radiation exposure. Okay. Okay. Okay.
Hands का part ना out of times. त्याचं म्हणजे तू सांग ना त्यांना announce द्या announce.
So, anybody else have any doubt? That means you understood everything. Hmm? Okay. See, we are gonna break for 1 hour, one till 1:30. You come back. Okay. After that, we have a live demonstration of intraoral camera scanner. They have bought it from Sirona. Okay. Omniscam, they have bought it. So as sir told to how they integrate CBCT images with CAD/CAM machine. So for that, so for gingival thickness and all that, you need scanner. Okay. That scanner they have bought it. Okay. So that demonstration will be done after lunch. Okay. So please have your lunch and gather here again. Okay. Thank you. बंद करो.
Last method, there is no option, there is no issue of saliva or something like that. But when you're going to do it in the patient's cavity or oral cavity, obviously there would be a saliva. तो उसको भी कभी कभी थोड़ा सा delay हो जाता है. But I think it's hardly 1 or 2 minutes. You can scan both the upper and lower jaw. It's very easy. Okay, so it's just simply you have to follow the music, and at a roughly 45-degree angle, you have to start scanning it from the posterior region. So, and you have to scan the entire region. Suppose you just want this area, itna scan karo. Same thing with the upper jaw, and automatically then it will take the bite and it can proceed. You can design your entire processes. Like suppose you want to design a crown, you can select the material on this. Then you after the prep, just do they take an impression of upper as well as lower. It will take automatically the bite, and then you can select the material. And if you have a milling machine attached, automatically it will mill the crown, and within half an hour you can fit the crown in the patient's mouth, and he's happy. The entire process. Okay, so generally, I think in Nagpur itself, Dr. Arya has this thing. He, as far as I know him, he has this CEREC system, and so he also does a single day practice for with such patients. So that's how it is. So someone wants to try? Anyone wants to try? Aja. पकड़ो इसको. Yeah. Pen grip पकड़ो इसको. Go on scan. Wait. Actually already done. So what we can do? You can take upper jaw. Take an upper jaw. Yeah, nice. Take from posterior region. Arms. No. See, he's doing it for the first time. Still, it's quickly it is grasping. I think Densplay has got a customer now. Okay. Yeah, ये देखो. He's almost scanned it properly. Anyone more? One more we can give someone. I think delete कर दे. इसको delete कर देते. Yeah, we can have buckle. Okay. Now we'll do it again for the lower. Yeah, sure.
So in maxillary cast, you have to scan the palate and all.
It will automatically take space. This is mandible. Pen grave. So, इसको ही कर देते ना. इसको ही कर देते. Yeah, take a 45-degree angle. थोड़ा सा. Yeah. Generally, the interdental area sometimes get missed, so that appears as a blank area, so you can just rescan that area. Go from the lingual side. लिंगल थोड़ा करो, थोड़ा नजदीक रखो उसको. ठीक है ठीक है. Just wait. Yeah, then you don't have to scan that area. It's not required. You take it out. So, yeah. Now see, we have taken the lower jaw. We have taken the upper jaw. Now we take a buccal bite. हाँ एक मिनट हो गया सर. Last. And now it will automatically calculate. वो स्कैन बराबर है आपको स्क्रीन पे देखिए पेशेंट देखने की जरूरत है स्कैन कर मुझे आपको बताएगा आप सही कर रहे हो.
PGs, you can also try by yourself. The scanner on the model will be displaying that on the screen. Okay. So after once sir gives demonstration, you all PGs can try that. Okay. The audio which was playing, that was an audio signal, because it is an audio signal key camera is scanning. Like you don't need to look at the screen also. This audio, how you give an audio signal, you just look at the patient and scan it till the audio is playing. That means it is scanning. Once it is done, the audio will stop. That means it has taken all the images and then it will start processing. Okay. Meanwhile, we would like to felicitate Dr. Jaju sir with the hands of Dean sir.
Thank you, sir, for your precious time and the knowledge you shared with us. Now, Dr. Deepak Nagpal, sir, will felicitate Dr. Prashant Jaju, sir, with the certificate and memento. Now I will call upon Dr. Zarish ma'am for the vote of thanks. A warm and graceful afternoon to all, to our honorable chief guest, Dr. Prashant Jaju sir, dear teachers, my colleagues, and everyone gathered here. It's my privilege to propose a vote of thanks and acknowledge the contribution of those who have worked really hard to make this event possible. I, Zarish Akhtar, on behalf of my Department of Oral Medicine and Radiology, extend my sincere thanks to the Almighty for making this event a grand success. And I would like to extend a hearty vote of thanks to our chief guest, Dr. Prashant Jaju sir, who spared his time from his busy schedule to grace this occasion. Today we had an opportunity to hear your thoughts. It is my pleasure to thank our Honorable President, Shri Sharadji Kalmek sir, Honorable Secretary, Shri Hemanji Kalmek sir, for giving us this wonderful opportunity to conduct this CD program. I would also like to thank our respected Dean sir, Dr. Deepak Nagpal sir, for his constant support and guidance. An event like this cannot happen overnight. The wheel started rolling week ago. It requires planning and a bird eye for details. We have been fortunate enough to be backed by a team of very productive technical team and a dedicated staff. I would like to thank our support system, Dr. Ashish Lanjegar sir and Satavne sir, and all the staff of oral medicine. Last but not the least, I would like to thank all the participants for patient listening. Thank you so much.
Hello. So, a very good afternoon. I am Pratik from Dentsply Sirona. I'll quickly take you through our basic software of Omnicam. Omnicam scanner is from Dentsply Sirona. It has got 35 years of legacy that it is working on intraoral scanning technique. And I mean, it of course works on AI, and during a period of many years, it has evolved to a certain extent. Now that we have another scanner recently launched, which can even scan edentulous cases also. Okay, so these are basic. Once you open the software, this is what you get. You feed in the details of the patients. You can even have your dentist name and entire thing mentioned over here. So once you have feeded that, then comes the acquisition part. So we have already taken few demos. So this is what the data that you acquire by using this intraoral scanner. Then there is third tab which mentions model. So it will create a 3D model, just like you have this cast right now. So this would be like you would be sending it to the lab, and instead of sending this, you can send that 3D file of the 3D model that you have created to the lab. Okay, and then they will definitely work on it. So I'll again, start fresh for a few of our volunteers. So please, those one by one, if you want one. So if you want to have like, you can add few patients. Yeah, we all do. Not this one.
Because I think so manually would be a very
Yes.
because this is just
Yeah.
hard tissues, I guess.
Yeah. So this is the basic odontogram that you would be looking at. And so you need to first of all define what kind of restorations that you would be doing. So for single unit, this is tab. In single unit, you have crown, inlay, onlay, veneers, implant if you wish to have. Then there is another tab which has like for bridges. So 3-unit bridges. So for that, you need to define just a pontic where your bridge would be lying. And then this is the third option for your aligner cases and orthodontic cases. So according to the case, I guess if you wish to define what do you want to do with this, so you can like just select accordingly.
This is basically a maxillary arch with missing both centrals and both lateral incisors. So basically, we are planning for a bridge. So we'll be scanning this cast for a PFM or a all silk or ceramic bridge. This is 1112 and 2122. Yeah, yeah, anterior. We'll be taking support from both the canines. Yeah, yeah. Missing tooth is 1211 and 2122.
Now you will select the material. So these are the choices that you have got.
Yeah.
So shall I select?
Yeah, zirconia.
So the reason that is asking so many data from you, because this 3D model which you will be sharing, it will be shared to the lab. It would be shared to the lab, and so that the lab people will get to know what are the kind of like inputs that you have given. So you need to select the material, you need to even select the shade of it, because it has got color calibration, so it will properly detect your shades.
Shade A1 or A2. Yeah.
If you wish to have a stump shade, that you can also define it. So this is what now you have defined. So your case details are here: bridge, zirconia, 12222, and beta classic A2 shade. Now you will acquire the data. So it is automatically asking you to scan upper jaw. So you can scan. Yes, no, you can scan entire jaw. Yeah. So initially you need to go occlusally, then you can go, towards थोड़ा बहुत बक्कली आके, and then you either tilted बक्कली or lingually आपके हिसाब से. So you can even touch the surface of the tooth, because this is this sleeve is SS made. No need of like no fluid penetrating inside, completely hygienic, sapphire glass, so no need to worry about it. You can hold it like a pen and even go closer. Yeah, so you can hear this rhythmic sound, so it shows that you are going perfectly fine. If the sound is arrhythmic, then it means that you are going slightly out of focus. Go slow, occlusally first. You're going out of focus, and come back to the previous reference point. जहाँ से पहले चालू किया था, और पीछे आ जाओ, और पीछे आ जाओ, और पीछे आ जाओ, यस, और पीछे आ जाओ,
Scanning it
yes,
first occlusely,
yes,
then buccally and lingually.
then buccally or lingually. हाँ, go closer, still, हाँ,
Okay.
yes,
Okay.
perfect. स्कैन कंप्लीट स्कैन कर लीजिए. All right, so you can see from here if you have missed out on, like, there are many much data which is yet to be acquired, so you can again start. Yeah, yes, so this part you're missing. Yes, perfect. Labial surface, yes. You can zoom in and zoom out. You can check if there are few places. This is yet to be, like, yeah. Occlusally stay, yes. Now tilt it towards labial surface. Yes. Nice. Okay, so we are done with the upper jaw now. If someone else wants to try lower jaw. Yes. So I'll just click on 1 second. Lower jaw. Yes. Start with posterior occlusally. Yeah. Yeah, you can even touch. Don't worry at all. Yeah. Perfect. Quadrant wise, either you go buccally or lingually as per your request. Yes. Perfectly fine. So in ideal scenario, you need to first basically consider few things, that you need to have proper isolation of the tooth, because fluid and blood is, I mean, saliva is a lot of issues. So you need to clean the surface very properly. You should use your suction and everything very properly to get the proper scan. Yeah. Okay. You can go occlusally first. Yes. Now delta. Yes. हाँ, थोड़ा सा रेफरेंस पॉइंट के लिए. No problem, no problem, don't worry. बाइट बता दो. All right, so we are through. We are done with lower jaw also. Anyone for buccal bite? Although it will show tick mark, but then of course, ma'am, as you very rightly said, you need to scan the entire thing. Yes. Use it, hold it like a pen if you wish, I mean, or as per your convenience. So start. Go closer or more closer. Yes. closer. So although it has shown you the tick mark, but still, ma'am, you need to take proper bright, because this data would be shared with your lab. Yes. You can move to the other side. So we are almost done. Done. Yes. Thank you. So after we just wait, I'll just again. So now this is how your 3D model would be created. And would you like to draw margins or prep analysis? So these all features are available in the scanner software only, that you can even draw the margins because you have seen the patient yourself. And then you can even do prep analysis. You can undermine what are the undercuts and everything. So all this software enables you to do such kind of things because you have seen the patient and you want all the data to be given to your lab. So this is your model axis. I might not be able to do it properly, but then if you wish, yeah. So I mean, if you want to try, right click is basically you can move the entire thing, and then left click you can, yes. So you have 3D view over here, one to end this thing. Yes, that's right. If you wish to move it forward, that can also be done. Right click se thoda sa. Yes. Cut axis. Okay. So we need to. So once you like okay it, then it will have your trim area. So you can trim, and then I mean I'm not well versed with this thing, but then you can definitely try. Or else just for demonstration purposes, we go with margins draw and then yeah. Oops, system error has occurred. Yes. So here you can draw your margins. You have to connect the lines. You have to connect the lines. Yes. So you need to define your margins and everything. Yes. दो बार क्लिक करके you are actually this is ये margins draw रहा है. If you want to have redo, यहाँ से आप कर undo. All right, so such kind of features are there. So once you like draw your margins according to your patients, and then you can have your prep analysis that can be done. So by acquiring this, you will create a 3D model which you can share with the last option, that is the Connect software. So you can send it to your preferred lab partner via any format. I mean, generally 90% of the labs, they accept STL files, And even for our guided surgery, STL files and DICOM data can be merged, and you can have your surgical guides and everything prepared. Okay, and for your regular this purpose, you can this STL file can be sent to your lab person, and he can download it in his ExoCAD software, because that is how they are usually working on, and then your final prep can be shared. Apart from that, we by Dentsply Sirona, we provide a license to the user of this scanner. They can share this license to their preferred lab partner. So basically you have seen the colored 3D data that you are looking at, but mostly STL file is monochromatic. So although you would be very happy that you have taken a wonderful scan, बहुत मजा आ गया, बहुत अच्छा scan हुआ, but then ultimately that 3D model that you have created, you are sharing with your lab partner via STL file. STL is monochromatic, तो उसको तो monochromatic black and white ही दिखने वाला है. So we at Dentsply Sirona believe in, like, what you have scanned, you should share the same file and in the same format to the lab partner. So we provide you a license which you share with your preferred lab partner, और वो उसको जो DXD file, PLY file, STL file, whatever he is comfortable with, so that he gets the exact image and exact file that you have scanned. So that is how you can work on it, and you can minimize error very significantly. So we are talking about very micron level discrepancies. That's absolutely not, I mean, not the chance with such kind of scanners. Okay. So would you like to try? We have one more model. So if someone wants to try that, yeah, sure. So would you like to try that one? Yes, scan it occlusally first, and then either move it either buccally or lingually. One second. I'll just like add another patient. So just write down whatever it feels, or your own name. This one. This is your actual name. So you can define what is the case. So first of all, you need to define. Bridge. Okay. So will it go for bridge or single unit restoration? Single unit. So I mean case वैसा नहीं है, so you can like either merge this with this. ये हो पाएगा क्या? इसमें कुछ डिफाइन कर दो. Let's say veneer करना है किसी में भी, है ना? क्राउन और veneer. So या single unit crown ही लिख देता हूँ. ठीक है? Which tooth number? Is it like upper or lower? Okay. So material zirconia. I mean, since its aesthetics are A2. Okay. So we have defined the case. Now you can start scanning. So it's asking you to scan lower jaw first. Yeah, sure. थोड़ा सा मैसेज हो जाएगा. कैमरा के लिए. Yes. हाँ. Yes. Let's start occlusally. Yes. scan for aligners. Even this is Invisalign validated. Is it? Which scanner? Okay. Even this sound or the red mark, it will show that you're going slightly out of focus. Is that done or you are? Oh, nice.
मुझे dentist case का बताइए.
Edentulous case के लिए I mean no scanner in the world can scan, to be very frank. But हमारा एक upgraded है prime scan. वो
But is that even
it can even scan edentulous case.
is that even in the market? I mean,
हाँ,
is it in Nagpur?
नागपुर में है.
Yeah?
रामकृष्ण मठ.
हाँ?
रामकृष्ण मठ दंतोली.
हाँ हाँ.
They have prime scan.
Ramakrishna Mat.
Patient.
Actually, my one of the grandparent, we have a very huge history of gag.
So conventional नहीं जमेगा.
हाँ, तो it is impossible for her to do a CD.
You should go to Ramkrishna Mठ.
Yeah, so that's why I asked you CD के लिए option. Thank you.
Done? Oops. So we are done with the lower jaw. Don't connect next.
ये क्या वापस कर?
ठीक है, check complete. Then since it was 1, 2 so you can just have a zigzag motion to scan it.